All right. Good morning, everyone. I'm Brannon Traxler. I am the Director of Public Health at the South Carolina Department of Health and Environmental Control. A little bit of a long name, so we just call it DHEC. Today, as Asha said, we're going to be looking at short-term strategies. So the key being the difference with this panel versus the next one being that it's short-term strategies for strengthening the laboratory systems for emergency preparedness and response. And in particular, during this session, we're going to be focused on surveillance and early detection. So we're joined today, 3 in person and 2 virtually. First with Tracy Goldstein, is the Division Chief of the Emerging Threats Division of the Office of Infectious Diseases and Bureau for Global Health at USAID. Adi Gunlabhali is the Chief Public Health Informatics Officer with the Office of Public Health Data Surveillance and Technology at the U.S. Centers for Disease Control and Prevention. Sam Scarpino is the Director of AI and Life Sciences at Northeastern University and the former Vice President of Pathogen Surveillance at the Rockefeller Foundation. And then joining us virtually is Lauren Sauer, is the Director of Special Pathogens Research Network and the National Emerging Special Pathogens Training and Education Center, and is an associate professor in the Department of Environmental, Agricultural, and Occupational Health at the College of Public Health Global Center for Health Security at the University of Nebraska Medical Center. Also joining us virtually is Colleen Kraft, a professor in the Department of Pathology and Laboratory Medicine, Division of Infectious Diseases, and is the Associate Chief Medical Officer of Emory University Hospital. So we've asked each of these speakers today to share a few strategies or solutions that they think would make a difference for improving surveillance and early detection. So we're gonna start off with Tracy. Let's hear from you. Thank you. Stand up. Sure.
Good morning, everybody. Thank you very much for inviting me today. I'm obviously from USAID, so I'll speak today a little bit from the development and international lens. And I will do a little bit of framing just to sort of set us up for that. And I think it's interesting listening yesterday. I think a lot of the issues and challenges that we're facing domestically, we're facing internationally, but these are really exaggerated in low and middle income countries. So, sort of starting with the COVID-19 pandemic, it's a strong reminder of a number of things, but in particular, what a pathogen that spills over from animals can do to global health and economies. And I think that is the piece that sometimes has been lost in sort of the response because we've been so focused on the human aspect, which makes sense. But of course, as we also said yesterday, it's not just COVID-19. There was the recent Ebola outbreak in Uganda, the ongoing Marburg outbreaks in Equatorial Guinea, and Tanzania and Mpox, and all of these spill over from animals. And in fact, since the 21st century, infectious disease and epidemics have been increasing in severity and in frequency, and 75% of these are linked to wildlife primarily, and to contact with people in terms of resulting in spillover. And as we look at changes in land use and climate change, this contact between animals and people is increasing in more and in risky ways, and so these spillovers are going to continue. So this behavior and human contact is really key in understanding. So for the foreseeable future, every country is either preparing for a future outbreak or addressing an outbreak right now, or both. So we really need to be thinking about how can we expand our resources on prevention and detection so that we're not constantly in this response mode. And next slide. Sorry, and I did not realize I was talking all that time without moving my slides, so apologies for that. Next slide. So for those of you that are not aware, the Biden-Harris administration has placed a top priority on global health security and support to international partners. And this has been included in a core element of the recent National Biodefense Strategy that was recently released. And in particular, it states that the United States will make a bold commitment to support 50 countries in their ability to achieve measurable capacity to prevent and respond to diseases. And this including surveillance and laboratory strengthening. Next slide. So for more than 15 years, USAID has been engaged in these efforts to address emerging infectious diseases in partner countries. And in particular, we've been building preparedness to prevent, detect, and respond to emerging infectious disease threats. And we're in the process of currently expanding our programs into 50 countries in Africa, Asia, Latin America, the Middle East, Europe, and Eurasia. And in particular, building on a lot of the investments made on the COVID response, but starting to look to the future. What can we do to address future threats, and how can we strengthen surveillance and laboratory systems? Next slide. So I put this up because I think we want to talk about the different parts of an outbreak, and different diagnostics are needed depending on where we are in the outbreak. So all the way over on the left is the pre-outbreak phase, right? So this is when there's not yet human cases, and this is really where we want to be investing in understanding where is the risk, what are the species, what are the areas, what are the human behaviors. So this means it's a species biosurveillance in order to understand what is circulating and where, so that we can begin to understand how can we limit those spillovers. The second phase is when we have the first human cases. So what we need is early detection, so education in communities to understand something is changing, and then labs that can quickly respond and detect that so we can limit further spread. And then the third phase, of course, is where we hope to never get, which is a late outbreak phase, where now we have significant human-to-human transmission, and now it's really around testing, finding those positives, treating, responding, and isolating. So we really need to be thinking about different tools that are needed in these different phases so that we can safely collect, analyze, and then share information across sectors so that we can be able to begin to prevent outbreaks in advance or limit them at the early stages. Next slide, please. So there's a lot of talk about the One Health response, the One Health approach, and of course we need to understand the interconnectedness between the health of the environment, animals, and people, because clearly they affect each other. And so we need to take this holistic approach to understand what is happening, and this includes partnerships at all levels. I don't want to repeat them. I think we've been talking about a lot today, but this is really, really critical to forge these partnerships and bring in multiple sectors in order to do this work. So in the wake of the COVID-19 pandemic, we now see One Health approach included in a lot of high-level documents, all the way from revision of the international health regulations, all of the Biden-Harris administration documents, and inclusion into the pandemic fund. So I think the key here is how do we implement that in communities and show progress and benefits. Next slide. So, okay, to get to some of the strategies that we can implement right now. I mentioned the One Health response. I think we really need to be able to implement a One Health approach so we're working across sectors. This includes health, agriculture, wildlife, environment, and education. I'm not going to speak to this today, but the universities, especially in this country and other countries, played a really critical role in the pandemic and in that initial testing. So I think thinking about how we can pull them is important. And then we need to really be thinking about not just the public health system, we need to strengthen that animal health system. If we don't strengthen animal health laboratories, we will never get to that next stage. We need the animal health laboratories to have the same tools that the public health ones do, and the ability to report in the same ways across sectors so that we can learn from what they're detecting and then be able to be ahead of the curve to respond. Second, we need to not just, as I said, include monitoring of human populations, but we need to include wildlife, livestock, and vectors, and link that with the human population monitoring, because they occur and they affect each other at different times in transmission. We also, as I said, and this came up yesterday, need a tool, we need to employ different tools for detection. So traditional testing is important, right? Specific testing for one pathogen in a specific host is critically important. We needed to do that during the COVID response. But labs need other tools, and we talked about some of them yesterday, and these are broad approaches so that they can detect either multiple, evolving, or emerging pathogens. So some of these are not very easy to be automated, but there are assays and protocols that are out there. So they are broad, either viral families, so there are pan-coronavirus assays or beta coronavirus assays that have and continue to be deployed, and we deployed them in 63 labs across Asia and Africa so that you can detect known or relatives of known viruses within those families. And these are really critical in that they're agnostic of species and sample type. So they're a great tool to have when you're sort of going down your list of differentials, and it's not Ebola, it's not Marburg. What else might there be? A panfilovirus assay can detect that, and we've shown that to be successful. And we talked yesterday about how do we expand surveillance. It is expensive, but if you're testing a SARI sample for influenza, why not test it for other respiratory viruses at the same time and report that information out? When we do surveillance in animals, we don't have to do it all the time. We can target it. For example, Marburg virus. We know the host of Marburg virus. We also know from the good work that CDC has done that this virus is shed around and after the breeding season. So if we are sampling in places where these animals are living around that time of year and detect positives, we can alert communities, limit contact, and we can reduce spillover. So I sort of mentioned communities. We really need to be able to work with communities to educate them to identify when something is changing, when something is different, and then give them a way to report out so that labs can then respond and do the testing. So by connecting the surveillance and the lab networks with the ministries, we can both move data from the communities to the labs and then out to the ministries and then across sectors. So really building this network where there are known partners, labs can reach out to each other, they can reach out to communities, they know each other, and then share also across borders, which is the other critical piece. And then finally, we talked a little bit about global early warning systems, and labs obviously need to be looped into that so that the data that they're developing, whether it's from wildlife, whether it's from vectors, livestock, or from people, can be linked into that. The data can be analyzed and interpreted and then acted upon to either prevent outbreaks or in early response to respond. So I'm going to stop there. Thank you so much.
Thank you, Tracy. And Addie, the mic is yours now.
Good morning, everyone. It's really great to be here. Appreciate being here and also being invited to the panel. Thank you, Dr. George and the co-chairs and the planning committee. I really learned a lot yesterday being here, listening to all the panels, and really many of my views and experience was endorsed by many of you here. So I think that was a twofer for me. Now, following that global and the animal health, I'm an infectious disease physician, human, and an informatician. Data is agnostic, so I can do all of those data. So I'd like to offer my perspectives here. One quick word in the bio and my card that I've handed out, my affiliation will say Center for Surveillance, Epidemiology, and Laboratory Services. Just in the last 3 weeks, we're reorganizing at the CDC, and so my new affiliation is right here. It's Office of Public Health Data, Surveillance, and Technology, or DST for short. Next slide, please. So in looking at laboratory testing itself in terms of a probability and consequence matrix from low to high, you can see on the Y and X axis here. For us, even one laboratory test order for Ebola or Marburg or anthrax is actually very significant, right? We hope that we would be involved in that. Someone who's worried about this would have called their local jurisdiction, then the state jurisdiction, and the state would call CDC, and there's a group of us who would offer the consultation. But that is extremely significant. And like one of our colleagues, our veterinary colleague from yesterday who said, that inhalation anthrax case many years ago in Montana or the Midwest was only in the news, and it was just buried somewhere in the news. And I saw that, but it wasn't, prominently put up. So it's very high consequence, but very low probability. Now, we all thought maybe a month or so ago that laboratory testing for H5 would have been very low probability, but now we are doing it. So even on our own website and CDC website, you'll see that along with state local partners, there have been thousands, I believe about 6,000 or so workers in the poultry industry being monitored, and I think 100-odd tests performed, and one person positive for H5 in the past year or so. So that's there. So in March 2023, that's actually changed quite a bit, even in the last few days. And then, of course, Marburg, as we talked about yesterday and today. Mpox, all of you, we've talked about that yesterday. Luckily, in March 2023, we've gone up from a high of 400 cases per day, 7-day average, daily average, to less than 1 or 2 per day now. But now, if you see a resurgence of testing in any community, that is actually of consequence, right? So there's some populations that are being affected more, and that's very important for us. So laboratory test orders are just such an early indicator of some resurgence locally that we think about. Because you can't, the nation as a whole, but as you know, all local health, public health is all local most of the time. And then SARS-CoV-2, right? We'll never get away from that for at least the next few months to a year. It's really died down nicely. You can follow on our website. But again, it's regional and local in terms of what the community transmission levels are and what the testings are. And unfortunately, there's still a pretty high consequence for elderly and those with comorbidities, right? It's not over for the immunocompromised, et cetera, and all of that. So that's how I'm thinking about lab orders and generally. Next slide, please. So clinical laboratory testing data, and I'll stick to human specimens and lab testings for my part of it. But it's extremely critical for public health surveillance and early detection. It's literally the eyes and ears of what we have and what we do in the country. It's a rich source of information on orders and results. Everybody focuses on results, but I would say for the past 10, 15, 20 years that I've been working in public health surveillance, the orders are actually extremely important for us to look at. And that tells you a lot in terms of clinical suspicion. So what's going on the ground? We can say whatever the recommendations are at the national level, but if the clinician, the provider, is looking at the ED, in an outpatient clinic, saying, I'm suspecting this particular condition or has called a infectious disease consult and they're suspecting it, that's very important for us. I still remember and when there was a lull, after, in 2021, early February, March, when COVID was dying down and before the Delta wave was hitting us, one of my friends who works in an urban ED in the country actually told me a few weeks early saying, overnight I'm seeing more people being tested for COVID than there was even a month ago in February, And that was an early sign in one ER, and that's, duplicated elsewhere. So the clinical suspicion of our providers, our astute providers, and then they ordering a lab test is actually a huge trigger to know. And I think we have to harness that better in terms of how we do it. The volume of testing, so are you ordering one test? Yes, and yesterday I think we had some really wonderful questions about what is a trigger, right? Is it one test or is it rate-based or is it population? Well, for Ebola and Marburg and anthrax, it's one, right? For COVID, it may be 1,000 tests or 100 tests, right? For monkeypox today, it may be 10 tests. So I think it's very dependent on the situation and where we are in a particular outbreak or pandemic. I think it's very important. Who is being tested? And here, please know that having such respect for laboratorians and having worked in a clinical laboratory also, I have respect for what data the labs hold, right? We talked about that yesterday. We just cannot expect that all the data that we want are in the lab orders. I mean, if we can just get a name and make sure the identity is secure, I think we're about 90% there. So looking just at maybe age groups, is it pediatric being tested? That was very important in the monkeypox, Mpox outbreak early on, because there were family members and contacts of Mpox patients, and that died down very quickly. So imagine if in the middle of the Mpox outbreak we started seeing more numbers of children being tested, then you'd have to think about other modes of transmission. Sex at birth, that's probably the best we can expect from a lab order. Unfortunately, sexual orientation, gender identity is not available in lab orders, and we're cognizant of that. Where is the sample being obtained from? Is it an outpatient? Is it urgent care, ED, inpatient, nursing home? right? You see the niche populations here: dialysis centers, correctional facilities, homeless healthcare sites, homeless shelters. Is it a traveler? So some of these data are not available, but sometimes you do get where they were, either outpatient, inpatient, or in ED, right? Or in a special niche population. So we try to understand those. And where is actually quite important for the granularity. At whatever granularity we can get, is it this zip code, county, state, or region? Because again, when now we see COVID and Mpox completely dying down, we really want to know where those tests are being ordered. Is it all still in urban areas? Has it moved to rural areas, etc.? Test results, and gosh, we've talked about this yesterday quite a bit. The volume of tests, especially the negative test results, our partners have pretty much challenges in being able to ingest 10,000 negative test results per day. We understand that completely. However, at some level, that test positivity, when you have a numerator and denominator, is actually quite helpful. Now, there's limitations to that, and it changes locally and with time and the performance of the test, the prevalence of the condition, all completely agree. However, there's still something to be gained from percent positivity going from 50% down to 10%, or going from zero, less than 1%, during the waves of COVID back up to 5 and 10% in some areas. It does help you think through. And then trends over time. And I didn't want to present those today, but luckily our colleagues actually presented yesterday the COVID curves and the Mpox curves over time of laboratory tests, results, and percent positivity. They do tell us quite a bit, and the waves of how this goes on there. Next slide, please. So the laboratory testing flows, and I think this is quite important to take a minute for this one. So by law, laboratories must report certain conditions discovered during testing to state and local public health departments. They're called reportable conditions, right? And there's a group of maybe 70 or 76 or 100 now that are common amongst all states, but there's also some unique for each state. However, the data sharing from laboratories and state and local public health departments to CDC is generally voluntary. So that is actually an eye-opener for many people in the community, that the CDC, the federal government, does not have the legal data authorities to mandate or collect this. So there are exceptions for COVID-19. As you know, the CARES Act yesterday was mentioned. The CARE Act Section 18115 required every laboratory test performed for COVID to be reported to the Secretary of the Department of Health and Human Services. And for monkeypox or Mpox, CDC partnered with several clinical laboratories. That was brought out very nicely yesterday about the surge testing. And so we were able to receive as part of a licensing agreement for that. And there's several public health laboratories, most of them do receive funding and participate in CDC programs. So we do get lab results either through LRN or through other channels for those tests being conducted in public health laboratories. So, but it is voluntary, and that's a very important point to note on that. Next slide, please. So in asking us to look at short-term strategies for success, I jotted down a few, and I'd like to go through those, which I'm hoping would add value for public health. One is increasing coordination among our public health partners. We have quite a bit of coordination, and this was brought up yesterday. We just need to make it much more standardized, harmonized, and increase that collaboration. So we know who to reach out to in times of emergencies. Data sharing with appropriate public health data authorities, agreements, and safeguards. The U.S. government does not want to have data that we should not have, and so it's very important that we have safeguards in place and agreements and hopefully some level of data authorities and a combination. Data standardization and harmonization for improved interoperability. I wrote this last week and got it cleared and sent it to our colleagues earlier this week. And yesterday, I think the buzzword for the day was interoperability, right, at all levels. And that is extremely important for us. I mean, it is a challenge, and I think we have to do much better in being able to bring that consensus to everyone, and maybe a balance of consensus and some regulations and some guidance that we need to do. Linkage of laboratory data with case and vaccine data. During COVID, one of the biggest questions was, are the vaccines effective? And then later on, were you protected after an infection? And we at CDC could not link the case data that we receive from our partners with the vaccine data that we have, because both come in de-identified streams. And so several states can do that, and they were just amazing. I think 23 and then maybe even more jurisdictions that worked with CDC to be able to show vaccine effectiveness after the waves of that. But that should be something, and that same question came up for Mpox, and we can't, again, link the vaccine data with the case data at CDC, so we depend on our colleagues and our partners to be able to do it. And then I'm hoping this will resonate with many of you from the laboratory specimens versus unique individuals, right? So either at the same time, as you know, for Mpox, unfortunately, our patients had more than one set of lesions, so they did culture several and sent maybe even 3, 4, 5, 6 specimens per individual, but we couldn't deduplicate at CDC in terms of saying there were so many specimens tested this week, but how does that translate to individuals? And so please, we look for that guidance and help from source to be able to say specimens versus unique individuals. That comes up all the time. And then longitudinal data, and that came out in COVID in spades, right? So we thought it would be done with one wave, and then are you being tested again? Were you tested 3 months ago? Were you tested 6 months ago? And are you now a reinfection or another infection, subsequent infection, or after vaccine, et cetera? So, and then other testing that was done in COVID, they mentioned yesterday serology and other testing too. So that's also quite important for us to look at that. And then it was briefly mentioned yesterday and this morning, I think, about coordination of pathogen agnostic testing, which we think would be a surveillance tool in looking at that. And Tracy, thank you for making that statement about, if you're checking for one respiratory, could you check for a panel on that? And then lastly, I'll mention our office is in charge of the CDC's public health data strategy that is being developed in collaboration with our partners. And if we go to the next slide, I think implementation of that will also help. And if you look at the 4 major goals of our data strategy, this has been shared with our partners over the past month or so. Number 1 is strengthening the core of public health data. So ensure core data sources, and it's in small print at the bottom as a footnote, but it's case data, including electronic case reporting, lab, including electronic lab reporting, electronic test orders and results, ETOR, and then ED department through the National Syndromic Surveillance, et cetera, are more complete, timely, rapidly exchanged, and available to support the integrated ability to detect, monitor, investigate, and respond to public health threats. And I think implicit in that is trying to harmonize. Also, we're working with our partners on a common data set or a minimum data set also. So I'll stop there. And again, with a huge thanks for being invited here and for this panel on this. Thank you.
Thank you. And I find myself nodding along from the state public health department perspective with many of those facts. Sam, you're up next, please.
Great, thank you very much. Sam Scarpino, I'm the Director of AI and Life Sciences at Northeastern University in the Institute for Experiential AI. I'm also a faculty member in Health and Computer Sciences and was, up until 6 months ago, Vice President of Pathogen Surveillance at the Rockefeller Foundation, although I want to stress that I am not representing the views of the Rockefeller Foundation and no longer have an affiliation. I again want to thank the organizers and all of you. I really enjoyed yesterday and learned a lot, and the 2 speakers before me also inspired some ideas about things that we can work on as we go forward. I didn't prepare any slides because as an academic, it will be physically impossible for me to speak for 7 minutes if I have slides. So you'll have to bear with me with just the microphone. When I think about short-term strategies, in my mind, that means that these need to be things that we're already doing, right? And that with some coordination and funding, we could realize benefits in the immediate. And in the context of public health labs, one of my early experiences working with the Association of Public Health Labs and the CDC around their right size roadmap and sample size collection for influenza strain selection, one of the things that has stuck with me is how many different tasks and how complicated they are that we need public health labs to perform. And I think what that means is that there are always going to be trade-offs, right? Absent infinite resources, we won't be able to do everything at the same time. So in the context of influenza, finding low reactor strains is a major challenge unless you have existing information on where positive cases are, right? You can't sort of do population level surveys for viral, we'll probably start calling them variants now even for flu, but viral variants that are way under 1% of cases. You have to be able to target them. Similarly, if we're asking public health labs to perform complex testing or testing for a wide variety of pathogens, we really can't expect that they will be able to scale up to the kinds of volume that we would need to actually control transmission. And so I think there are 3 areas where we can offload some of the burden and responsibility from public health labs. And a lot of the resources and expertise and technology are already out there kind of around the country and globally. The first is universities. So we've heard a couple of times about university testing, and I think one of the things we know is that it was different from university to university. So at Northeastern, I was on the faculty in 2020 during the pandemic. We tested everyone on campus every 3 days and kept the university open with no transmission all the way up through Omicron. Right? And so you can control transmission with a high volume of testing, but if you were to rank all the states in terms of COVID tests, Northeastern would have beaten 5 states in terms of the total number of tests that they ran, right? So just to kind of put that volume in perspective. But Northeastern's CLIA certified lab is still sitting there. And Northeastern is not the only university that ran tests at this volume. And in fact, most universities had a lab that was at least running volumes that would be comparable to public health labs, in some cases, even some commercial labs. And the universities are sitting around asking, what do we do next with these resources, with these highly trained laboratorians, with the expensive equipment we've invested in, with the CLIA certifications? And so I think there is a real opportunity to engage the university network of labs as a potential scale-up mechanism for high throughput testing. And universities, just like public health agencies, are also local, right? I mean, there's a college or university, not in every county, but spread out throughout the United States. We actually published a paper. Took us a while to do it because figuring out how to get the stats right were a bit tricky. But what we showed was that university testing had the predictable direct effect, which is that it saved lives and improved livelihoods on campus, but it also had a strong indirect effect on the community. And we know this about testing, but to be able to demonstrate it by doing the right kind of case controls with counties that did and didn't have universities took a bit of effort. So I think that's the first, is engaging universities. The second is wastewater surveillance. All over the United States and globally, communities started wastewater surveillance. And why did they do this? Well, part of the reason they did it was because it's pretty inexpensive to perform wastewater testing. It doesn't happen typically in a clinical setting, which means you don't have to have healthcare providers collecting samples. You can typically inactivate them before they have to go into the lab, and so it reduces the complexity there. You're not diagnosing anybody, and so the requirements, now we should ask, maybe there should be some more regulations around this, but the requirements right now to perform the wastewater testing are relatively minimal. And usually the only permission you need is from whoever manages the wastewater treatment plants or the municipal water authority. So you don't need much in the way of permission. It's not very expensive. And what we've seen during the pandemic is it provides an incredibly rich source of data, right? You can go on the wastewater scan website and globally, around the United States, you can look for Mpox, human metapneumovirus, RSV, influenza, SARS-CoV-2, and norovirus. And there's real action that you can take from that information, right? So during the Super Bowl, norovirus was way up and respiratory infections were down. We should have had messaging around, remember, we're not wiping down surfaces. Well, now we are wiping down surfaces because it's norovirus, not SARS-CoV-2. There was a school district that had wastewater surveillance operating on the schools in the United States. They had a cluster of sick kids. They look at the wastewater. It's norovirus, not SARS-CoV-2. They go in, they bleach the desk, the kids are back in school the next day, right? So you can actually keep schools open with testing. Now, what does this mean for public health labs? Well, one of the downsides to this starting from the bottom up is that data interoperability is even harder now because everybody's using a different PCR test. Some people are doing sequencing and not PCR testing. Everyone has a different way of normalizing, et cetera. And public health labs will probably need to take a leadership role in the data harmonization, in advising on mechanisms for testing, et cetera. But I think there's an even more important mechanism, which is you can see where different pathogens are in the population at much lower cost, which means that the public health labs will have time to prepare, but also to target sample collection, right? So we could be doing sequencing of influenza virus in the wastewater, looking for potential low reactors, and then CDC could target specific clinics or public health labs for additional testing to find them and bring those back in for virologic analysis. So we could be doing this across pathogens. So I think wastewater surveillance provides an opportunity to gather the kinds of population level data that we would need to offload some burden from public health labs, inform public health lab operations, but then also help us prepare for the next threat. I don't know how many of you were paying attention to the Legionnaires outbreak in Argentina, but the thing that caught my mind is if you hold up the ProMed mail alert for that with the cluster of cases in Wuhan in December, the text is almost the same. And in fact, a couple ProMed alerts later in Wuhan, they're arguing about maybe it's Legionnaires, and as soon as the samples come back from the micro lab, we'll know that it's a bacterial pathogen and we're not going to have to worry about it. Now imagine that we had wastewater surveillance running in Wuhan, running at the rural area in Argentina where those cases were. We would not have known definitively, but we would have seen Legionnaires in the wastewater in Argentina, and that would have clued in what we needed to be testing for. Similarly, we would have seen a novel beta coronavirus in Wuhan, and that would have alerted the globe certainly much earlier. Now imagine that we had wastewater surveillance running in northern Italy, the east and west coast of the United States. We would have probably been able to stop the pandemic, right? So wastewater surveillance. And then the third, I'm sort of obliged to talk about artificial intelligence. The third is AI. Now our unique approach, not totally unique, but our unique approach to AI at Northeastern is the word experiential. So what does that mean? It means two things. One, training the next generation of decision makers that will have to rely on AI tools as a part of their decision process. These things are coming whether we want them or not. And that means individuals in public health labs are going to have to be upskilled. Individuals who make decisions based on data from public health labs are going to have to become familiar with how you include and evaluate AI models as a part of the decision process. So that's something that we're going to have to embrace, and the educational resources are there immediately. So we could start doing that kind of today. The second is human in the loop, right? So what you can do with a computer plus a human is not 1 + 1 = 2, it's 1 + 1 = 4, 5, or 6. And so things like building artificial intelligence models to predict where additional samples may be located, right? So you sequence a bunch of influenza genomes, you have some information about their location, you can use AI models to try to predict where samples might be located, where additional cases could be. You can use artificial intelligence to improve data interoperability, right? That's one of the things that it's quite good at. You can use artificial intelligence to streamline reporting mechanisms, right? A lot of the reporting that we have to do involves fairly similar kinds of data entry tasks, and that isn't meant to remove the humans. What it's meant to do is free up the humans for more things that we're better at than computers, like contextualizing the data, communicating it, gathering more samples, working collaboratively together, et cetera. So I'm going to end there. So just three things where I think we have the resources now. We can invest in scaling them and invest in interoperability coordination playbooks and realize benefits immediately. And that's around universities, the existing lab infrastructure they've invested in, wastewater surveillance, and then preparing for and starting to think about how we would integrate some of these AI models. Thank you.
Thank you, Sam. And so next, Lauren and Colleen are going to virtually present together for us.
Good morning, everybody. Can you hear me?
Yes.
All right. And can you hear Lauren? Lauren,
Can you hear me?
Well, thank you so much. I have to say that listening, I really wish I was there in person, and listening to what's already been discussed sort of makes me feel seen a little bit. So I'm very excited to be able to share and be a part of this panel, even though it's remotely. So Lauren and I are going to be talking about tag teaming on special pathogens diagnostics for clinical readiness. My background is also as an infectious disease physician. I'm also a clinical microbiologist, so did a pathology fellowship, and then also coordinated our system COVID testing and did a lot with our Mpox testing. So very excited to be a part of this group. And Lauren, I don't know if you want to say 2 sentences about your background as well.
Yeah, happy to. Thanks. I'm Lauren Sauer, and I'm at University of Nebraska Medical Center and direct the Special Pathogens Research Network, something that actually Colleen pretty much envisioned in the early days of the Ebola outbreak of West Africa in 2013 through 16. So I think with that, we can jump right in.
Yep. So I also, another thing I should tell you about my current role is I'm also currently the president of the American Society for Microbiology. So I don't know if anybody's heard of that organization. It's one of my favorites, of course. And so also having that perspective and that lens as we think about going forward. So obviously institutions, federal, et cetera, but I think societies play a large role also in education. And you're going to see how this work, which really came out of Ebola care in the United States, really has helped us to set up a framework, we think, in terms of testing in the United States. So I don't want to read all this to you, but you should know that the National Emerging Special Pathogens Training and Education Center is to really set the gold standard for preparedness. Obviously, this includes laboratory testing. The vision is really this culture of readiness. And if you think that we are ready at this moment for like another pandemic outbreak, I would love to talk more with you about that, because I think even in my own hospital, we are waning in terms of our interest and readiness energy. And then we also, you should know, if you've never heard of NETEC, it's netec.org, and we provide technical expertise, training, education, and best practices. And we're about to have 13 sort of ASPR-funded regional emerging special pathogens treatment centers. So we think that even though I think what's been covered already by the previous panelists is extremely comprehensive, I think this is yet another way we can sort of work on this problem. And here's where they're located. The 3 that are coming, I believe, are in Boston, Chicago, and there's one other one that I don't remember off the top of my head. But otherwise, these are placed strategically in the 10 ASPR regions. So that's the intent of this, and that's why they were chosen. And we have been working together as a group really since 2015, when this was funded by ASPR and CDC to look at the clinical care of special pathogens and readiness of hospitals for special pathogens.
So the one of the ways we're planning to build out testing capabilities into the structure of the National Special Pathogen System of Care, which is a vision for special pathogens readiness and early outbreak response in the United States, with a goal of 0 preventable deaths. And one of the essential elements of that goal, or of these goals that you see on the screen, is early clinical diagnostics, clinical decision making, so that people can be moved into the appropriate level of containment care quickly to reduce community spread of special pathogens, and reduce the likelihood of nosocomial infections. And this system is very new, and it's in the process of being developed, but the framing is similar to that of the National Trauma System, where you have tiers of readiness, and the structure looks somewhat like it looks like this, with a goal of having a coordinating body that will have functions of standard setting and guidance provision, monitoring, evaluation of data that comes through the system, and a huge focus on that early identification of special pathogens patients. And there have been challenges with building out this capacity for special pathogens testing in the United States on the clinical side for quite some time. And our focus is really on those, you'll see on the far side of the screen, those tier A hospitals, which represent the regional treatment centers. So they are hospitals across the country that Colleen was just discussing that really focus on early care and containment care of special pathogens patients with limited disruption to the rest of the hospital or health system. So carefully trained teams, both on the clinical side and the laboratory side, to maintain the highest level of care for these patients, but also to do early diagnostics and routine testing in the containment care environment. So during the most recent Sudan virus disease response and support of the federal government, we looked at opportunities to improve the readiness of these regional treatment centers. And really, one of the big focuses that I'll highlight here is on building out that clinical testing for case identification. So, you know, as the network currently relies on the state and local health departments and the laboratory response network, we also felt like having testing capacity in these facilities was critical to a reduced disruption of care across all tiers of the hospitals, but also in ensuring that patient gets care as quickly as possible, because I think we all recognize that special pathogens testing can lead people down pathways of containment that they may not need. And so the goal here was to support all 10 regional treatment centers and the NIH Clinical Center to onboard testing capacity for Sudan Ebola virus. We decided to use the BioFire machine and their Warrior panel, which is through their DoD initiative, and that we would implement this at all 10 regionals in the NIH Clinical Center to ensure that they had quick testing for clinical decision making. And the process was in collaboration with the CDC and with JPEO at the Department of Defense. It was an incredibly unique and valuable experience, and just goes to demonstrate that there is real utility for this testing capability, but also that we need to expand our toolkit of testing. I'll hand it back over to you, Colleen.
So obviously we've talked about sort of public health laboratories. We talked about how we do things sort of at a larger level. But I think one of the things I'm passionate about is, you know, really how we test in our clinical environment. So we have already talked about, you know, the need for calibrators for different assays and different things. And, you know, for a while we've had these tests. So thanks to this initiative that was really led by Lauren, we were able to validate it so we could actually, you know, feel like better about the results and not just sort of say, we think this could be the case. And so I think that clinical practice guidelines for diagnostic test utilization is really lacking. I'm, of course, passionate about this, both from a local hospital laboratory, but also a special pathogens laboratory, and then also the thought of how we interact in general with special pathogens testing, because it's not that we can say, sorry, you're carrying a category A agent, you can't be tested here because we don't have a category A laboratory. These things have to happen. We don't know who's going to show up. And so we have really been focused a lot on how to figure out how to balance some of those, realizing that we're not going to be all select agent centers, and realizing that we're not going to have FDA cleared diagnostic assays. But we have, with this kind of consortium, the NETEC group, we've actually got proper access to sort of, you know, DNA and specimens that we can test safely in a non-select agent environment to be able to rely better on our assays.
And so on the BioFire side, we really focused on using the same pathway that CDC was using for the LRNDs. And I think this worked really well so that everyone was on the same page with what materials they were receiving, what the expectation was for verification of the test, and that there was a clear pathway to completing all the requirements for bringing on this test. And then as we move forward, thinking about how can we expand our lessons learned from that exercise or that experience to really build out our toolkit more broadly.
So we continue to validate additional targets. Since there happens to be Marburg outbreaks going on right now, that's a clear next target. We are working on a network-wide laboratory-based diagnostic program. I will say that you might say, well, we don't have like a next-gen sequencer in everyone's laboratory to be able to de novo, but I think what was said, by the first speaker, which is in some ways we can rule out some aspects, or at least say we think today, obviously, we may need to test the next day if the person still has symptoms and is not doing well, and maybe we think we might have missed, got an early window. But I think, one of the things that some of these panels can actually help us with is at least rule out some very stressful things so that we can, treat the patient for what they may have. In our hospital, we've had laboratory samples sent from other hospitals worried about Lassa. It turned out to be something else, but at least we could go downgrade on the personal protective equipment to care for that patient who's critically ill. And obviously we want to define and refine the appropriate role for expanded diagnostic and clinical testing in this environment. Again, balancing that whole idea that we're not select agent centers, like we're hospitals caring for patients. And then obviously grow the collaboration with CDC and LRN and expand our clinical and public health laboratory coordination.
Yeah, and this last bullet I think was really essential during the Sudan virus disease outbreak, but also as we think about our forward-looking plans, really identifying the use case for these regional treatment centers to have testing and how they'll work within their region to support clinical decision-making. As of right now, they're not doing referral testing for outside of their health system or their hospital. However, you could imagine that there would be circumstances where this would be an incredibly valuable asset for a region that has either fewer LRNs, or if a specific assay is not available at their local LRN, that these regional treatment centers can work in collaboration with public health to ensure really quick and effective diagnosis of these special pathogens or ruling out of these special pathogens. And so one of the goals that we've set for the next year is focusing on the documentation around how do we decide what patients get tested in this space or not. And so I think there's an opportunity for clinicians to have a conversation or clinical environments to have a really forward-looking conversation on what is the appropriate use case in these special pathogen centers or in these regional treatment centers. So I think with that, we'll leave it and hand it back over to you all in the room.
Thank you, Lauren and Colleen. And before I see some lining up for questions, before we go to the audience questions, I do have some for several of you. So Sam, starting with you, the wastewater surveillance for COVID-19 really has just taken off since the start of the pandemic. What do you see, and you touched on this a little bit, but what do you see as the next condition or specific scenario where it could be successfully and quickly implemented, and what might the hurdles be in doing that?
Great, thank you so much. So I think one of the things that we will see with wastewater surveillance is just more routine surveillance happening, right? The CDC has invested in that and has a team of people who are working on wastewater surveillance. There's a live dashboard where you can get real-time information, and I expect that we'll continue to see more and more information about what is causing illness in communities be available through the CDC and through local efforts. So I think the answer is kind of all pathogens. I've yet to find one that isn't shed in some form into the wastewater. I think the biggest challenge is going to be around standardization of data and methods. I know this is something that the CDC is actively working on, but there are limits to how much you can do on the data analysis side if everyone is testing using different equipment, different protocols and standards. And so I think the biggest barrier is going to be around interoperability of data, but as a consequence of the myriad ways in which we're using testing for wastewater.
Thank you. And Tracy, how is the way in which people interact with our environment and animals within it changed the need for and the type of surveillance that's being performed for zoonotic diseases?
Thanks so much. I'm going to actually first just add really briefly something to what Sam said. This wastewater sampling, if something new shows up in the sample, we also have the ability to look at the host DNA in that and to try to link that to the source. I think that's the other really critical piece with some of these environmental samples. We can detect the pathogens, also detect what host species DNA might be present, and try to make that link. So I just wanted to add on top of that. I think your question about, so as we see land use change, climate change, the buffers between where people live and animals live are disappearing, whether that's wildlife or whether that's livestock. Labs do need the ability to detect, but the key thing here is lab results aren't going to change outcomes. We need to understand how those animals and people are coming in contact, how that behavior is changing. And then once you detect something in an animal or in the environment, you have the ability to target behaviors in communities so that you can actually start to think about how do you prevent spillover. So I think the key here is really human behavior and how that's changing, understanding where that's changing, where that contact is and with who, so that we have some ability to actually intervene prior to an outbreak.
Thank you. Yes, because I found human behavior to be so easy to change. But
data, right? So
right.
We talked about the Marburg example. If you can show that bats are shedding Marburg at a certain time of the year, then you can put out really targeted public messaging about that versus just saying don't touch bats, right? Which isn't realistic.
True. And I do think that seeing those more targeted messages are more likely to be successful. So Addie, we're talking a lot about interoperability. You mentioned it, and it was mentioned a lot yesterday. It's certainly an important theme. How do you envision this improving, given the different constraints that there are on data sharing and on data systems by each local or state public health authority?
Yeah, thank you, and really appreciate that question. I think it's multifaceted. So maybe take it in 2 or 3 parts. One is really, I think, consensus and a shared vision is very important. So like it was discussed yesterday quite extensively, that if all of us come together and talk about that minimum data set, common data set, and then some standardization in those data elements, I think is very important. Number 2 is trying to, as best as we can, map those data elements to a standardized vocabulary, terminology, US CDI, those efforts that are ongoing. And the third is, I think there's, it's probably going to be a balance of our consensus reaching along with some regulations and data authorities. And it's actually quite important for us to note that we have a website where we've talked about, the CDC talks about legal authority or data authority and see why it's important. As you know, data used by public health comes from a variety of sources. And while some data authorities exist at state, local level, federal authority will result in more efficient and effective information sharing prior to and during emergencies. And that will also help us with standards for data reporting implemented at the federal level. That'll help at the state and local level also and enable us. So I think it's multifaceted and it's going to require all of us coming together on that. If I may, just one point to add to Sam's and Tracy's about wastewater. The success was in finding polio in New York State. I grew up in India and I've been here for 30 years in the United States. I never thought in 2022 I would hear the word polio and United States in the same sentence. And so Rockland County and those areas. I think that is a success story that has been and should be recognized, I think, of the ongoing, that people have been doing that in silence and quietly for years, and that's how they were able to detect that. Yeah. Thank you.
Thank you. And the last one that I have before we go to our folks in the audience, Lauren and Colleen, how can the interaction between the clinical laboratories, the medical providers, and then the public health authorities be improved to help streamline that initial testing processes for the early detection, as you all were talking about? I mean, that's so critical for these new or novel pathogens.
Yeah, it's such a great question. I'll just take a quick stab and then hand it over to Colleen. I think that the data systems is one place where it's essential that we sort of refine them, but also make them more efficient and easier. I think that there are ways in which we can improve reporting, both from the clinical environment to the public health labs, and then also sort of making those data flows a two-way street so that it's a collaborative relationship rather than just sort of a one-way push of information, and build on those relationships via training and exercise, right? So making sure that we build those communications into our exercises, as we do with anything else. I also think that on the clinical diagnostic side that we were just talking about with the regional treatment centers for the special pathogen space, we're going to have to really define the use case and make sure that both national public health and local and state public health are on board with that use case, and that we're building in redundancies, but not building in systems that bypass other systems just because they're challenging. And so making sure that that the diagnostic capability is there and available to our sites that need it, but that we're not overusing it, right? So that we're using it the right way and learning from the lessons of the Laboratory Response Network, learning from the lessons of the CDC to understand the appropriate times to use those tests.
Yeah, I think what I would add on it is a little bit more of like a hospital level perspective, which is, it's also nice because I'm on video and I don't have to, nobody can talk to me about what I say after this, but we should have the testing that occurs should be in the hands of the people that do it the best. So I love you, CDC. You're our next door neighbor. I work with you a lot, but you don't need to be the referral laboratory for all of the United States for when we have a pandemic, right? Let's put that into the hands of people that can scale that up. I don't think, so again, this is me speaking from my desk and not being there, but I think trying to think about leveraging the strengths of each organization together, right? LRN is amazing. Hospital labs know what they're doing. They can be trained to do things. We know how to follow regulations. And then for providers, we were much better in MPOX thanks to SARS-CoV-2 because we had a sense of like how we wanted to educate physicians and providers on ordering and what we allowed them to order. And we quickly understood that like not having, using a different swab than we used for SARS-CoV-2 didn't make sense to us. Like, we don't need to buy another set of swabs. So, trying to like quickly push it into what we felt like was a clinically practical tool helped us immensely to like go from being panicky and sending everything out and having to handwrite everything to the state lab to being able to build in our dying medical record because we were just about to go to Epic. So we actually built in Cerner an order so we could order MPOX. It made a huge difference in everything and how we were able to manage and work on these patients.
Great, thank you. So we'll go to our audience now. We'll start over here to my right. And just everyone, I'll remind you to please start with your name and affiliation. Thanks.
Thank you. Is this on? Okay, great. Bill Meyer, Quest Diagnostics, clinical virologist, worked in labs, various levels, and now I'm in my 49th year. Seen labs improve in terms of technology tremendously. But in terms of how we deliver reportable results for action, we're back in the 1940s. Now, it's not likely that in short term we're going to change all the laws and all the jurisdictions and all the reportable diseases and all the forms and everything else. So let's keep doing that because we have to. Let's step out of that for a moment and move to what Adi's suggesting. Utilize licensures from the CDC to maybe 5 major commercial laboratories for all infectious agents, all orders, and the results, which can be supplied in a HIPAA-compliant manner for public health usage. Not names, but this is surveillance, where you have the surveillance already happening. It's just not being put into the AI formulas and all the sophisticated activities the informaticians would love to use. So I'm not, going to come up and say heresy. We have to eliminate reportable disease reporting through county health departments, state health departments. That should continue. But what we could do short term is set up contracts with large commercial laboratories, of which I represent one, that have a lot of information, a lot faster, and could be shipped in a real-time information transfer to do real-time surveillance. Thank you.
Great, thank you. Next up.
Thanks, Andy Pavia, University of Utah, representing IDSA, and I should disclose I was a consultant to BioFire, partly responsible for what's in the Warrior panel, I guess. This is a really great panel because it's focused on what we can do here and now, and I'm reminded of the words of Bob Weinstein when he was talking about getting hospitals to play well with CDC. He said, "You can make me or you can pay me." We've talked a little bit about the make me side, about streamlining reporting laws, cleaning up some of the confidentiality statutes, but I'm really interested in the incentive side. And I think we should be hearing from state health departments, from commercial labs, from university labs about, what incentives would help them solve these problems. One that I heard from Sam that I'm really excited about that I think we need to move forward on is using AI to improve incompatible data systems talking to each other. But I guess my question for everyone is, what are the incentives that people want? My friends at state health departments say they want access to the data that they're sending upwards. They want a really fully interoperable system. But what other incentives are there?
Great, and to clarify, you're talking what incentives are there for laboratories to report?
To improve.
Sorry.
Yes, for laboratories to achieve the kind of interoperability that we're talking about, so that there's seamless reporting, that there's easy access for clinicians, and that the necessary data for surveillance go upstream.
Great, and I'd like to get Addie's thoughts on this too, but I would say this is where we need to bring in some of our other partners too that control some of the funding mechanisms. I think speaking from a state public health laboratory perspective, we don't have the ability, we don't have the funds or the authority really to do those incentives, but that's where we would want to bring in the funders.
I'm a federal employee, so what we'll do is I'll request, I think that's a great point, Andy, and thank you, Bill, for your suggestion too. I think those points getting into the proceedings in brief here will help us at CDC to be able to look and then be able to pass that on to our own leadership also. So it has to be a shared vision and mutually beneficial. Thank you.
I'd love to hear from the hospital lab side too.
Lauren or Colleen, can you speak to this perspective?
I really love it. Sorry, Lauren, let me just say one thing, because I think it's the practical next step to what I was already saying, which is if you can, put people, leverage their strengths, how do you get them to leverage their strengths? Is it interoperability? Is it connection? Is it data sharing? Is it money? So I think it's a great suggestion.
Yeah, I agree with Colleen, and I think the other piece I would just note is that that when one of the incentives to invest in systems that can share data and systems that can improve reporting is that the system won't change in the next outbreak or in the next pandemic or in the next whatever it is. And so ensuring that the system is that when you're making those investments into the systems, that they are working towards interoperability, but also that we're all consistently working to keep them the same and just growing and better rather than waking up to the next new system.
I fully agree with that. And Eddie, you had a question?
Yeah, thank you. And for Colleen and Lauren, thank you for your talk. I'm not directly involved with the LRN or the special pathogens at CDC. There's a whole group of people there, but I work with them. I was wondering about data sharing through the regional centers and the results of the warrior panels or testing, because, in looking forward in terms of getting some sort of combined data set, and then I was told recently that all those RESP CTs actually are on Epic, instance of Epic EHR. So there's also probably something we can think about. So I'd love to talk to all of you. And Colleen, thank you for your comment. Several of us are getting on a plane to Atlanta this evening, so we'll see you there in Atlanta.
Sounds good.
Yeah, and just on the data sharing piece there, one of the things that the regional treatment centers is focused on, both for operational purposes but also research purposes, is a single IRB longitudinal cohort protocol. So ensuring that not just for operations but also for research, we have the potential to share data in a system. And we are all on Epic now. That I like to think that Colleen made them change to Epic when she took her new CMO role. So Emory was our holdout, and now we're all on Epic. So we do have an EMR coordination group that works on these very issues.
Thank you. Ren?
Ren Salerno, CDC. One quick question for Sam, and then a couple of comments for Colleen and Lauren. Sam, loved your point about university CLIA laboratories and leveraging them. Question is, do you have a sense, sounds like you did some research in this area, of whether universities, what percentage of universities were using laboratory-based, nucleic acid amplification tests versus, certificate of waiver antigen testing? So that's a question for you, and then that might be a quick answer.
I don't know off the top of my head, but the paper that we published will have that information in it, and so I can share that out with the group.
Awesome. Yeah, I want to make sure I get that. Okay, Colleen and Lauren, hopefully I'm a huge fan of NETEC, and we're working with you on a couple of small projects right now. Really also like your suggestion about adding the NETEC labs to the LRN, and completely agree with Adi that we need to work through the data sharing agreements, but that should not be difficult to overcome. And I think having additional reference labs for those particularly dangerous pathogens would be really valuable. My other comment for NETEC, but it's sort of a more general comment when we talk about these scary hemorrhagic fever viruses like Ebola and Marburg and Lassa, is that these are really rare diseases. And what actually worries me more, and I'm hoping NETEC can continue to help CDC with this messaging, is everyone who doesn't have Ebola or Marburg or Lassa, and the ability of clinical laboratories who don't have the technologies to test for those hemorrhagic fever viruses, but do have the ability to do standard diagnostic testing on patients for other conditions. And what is really concerning, even from CDC's old guidance, and hopefully we're changing this, is that we are, because we're focusing, we have this tendency to focus on the really scary stuff, that what we're doing is we're scaring 90% of the clinical laboratories out there from doing any testing, when they can do a lot of testing of suspect patients safely. And so how do we strike that balance to ensure that clinical laboratories can do standard patient testing in a way that provides an opportunity for treatment for the majority, but still we have the ability at the same time to do reference testing to identify these really rare, high danger or high threat pathogens. Thanks.
Yeah, so I'm just going to be concise, and then Lauren can clean me up. But the main thing is that the Respects and NETEC serve as a reference for those places. So if they have somebody come in and they're worried about those things, they have somebody in their region that they should know that can help them. So the way we've dealt with this with some unusual patient presentations is, there's a clinical syndrome, and sometimes the clinical syndrome is not a hemorrhagic fever, even if they're from an area. There's asking, exposure history. There's knowing the geography of the world, which sometimes is a problem, especially in like a triage nurse. I'm not being biased against triage nurses. I'm just saying that sometimes we think that one country is in Africa when it's actually in the United States or nearby. So I think we have been able to overcome some of those uncertainties in terms of testing or not testing by having really good infection prevention or infectious disease support. Now, you would also say maybe a place in a remote area doesn't have that, but I think that's what NETEC wants to do, is provide that sort of reference to be able to help. Wow, is this somebody that really needs this type of testing? The other thing I think we're working on a lot is being able to clinically care for patients and clinically test patients in a safe way. So clinical laboratories, in the way that they test things, for the most part, should have no concerns. They just have to really be adhering, and they're not necessarily all adhering. And I'm only saying that because I work in a local clinical laboratory, and I know that we've had to redo our safety things over and over again. When there was Ebola, we always kind of have to say, guys, you got to be wearing your gowns. You got to be wearing gloves. There's basic things that we do that we kind of we move away from. So I hope that answers your question, Ren. It's really good to hear your voice, even though I can't see you.
Yeah, and I totally agree. And I would just add that just a couple quick thoughts. One is that we definitely want to make sure that the use case for this type of clinical testing for special pathogens is meant to move people into the containment care or move people out of that decision-making pathway quickly rather than hinder their access to standard of care, right? So if testing becomes a barrier to people getting the care they need, that's when we have a problem. And so encouraging the clinical consultation process to still happen through state and local health departments, through the CDC, if you have a suspect patient or a patient that you don't have a good story on, that those consultations still happen, and the travel labs and everything else continues to happen, so that even if it's not, if it's the horse, not the zebra, that you're identifying, that happens quickly, right? So I think one of the goals of growing our testing capabilities in the regional treatment centers is to ensure that we're in lockstep with state and local public health and also with the CDC as to what's the appropriate use case. Because the best case scenario is we get people out of the decision-making pathway for a viral hemorrhagic fever, for example, quickly, or we get them into containment care quickly. That would be the goal of adding this additional layer of testing.
Great, thanks. And I think we're running up against time, but maybe one more question.
Sure. Scott Schoen, North Carolina State Laboratory of Public Health. Just to follow up on Ren's comment, the feedback that we've gotten from clinical labs and our hospital labs related to doing some of this diagnostic workup before a special pathogen is ruled out is that the manufacturers say that it'll void their warranty. So I think Matt said yesterday, a group that's missing from this discussion are the manufacturers. And so I think that that's an important piece moving forward, is to bring the manufacturers on these discussions as to why would running this void a warranty of a multi-$100,000 or $1 million equipment that's critical to test other patients. And so that, I think that sparks some of the concern and fear, or the lack of moving forward on some of this. That's not why I got up here. I wanted to talk about wastewater real quick and just say that wastewater testing proved to be incredibly helpful in COVID. But I think we need to be very careful and deliberate about moving forward and adding pathogens to know what we're going to do with those results before we get them. Yes, it worked for polio in New York, but there were clinical cases. But if you find polio in the middle of who knows where, is it because they have a good vaccination rate, or is it some other reason? And so the risk of sparking some concern, or as we've talked about, the misuse of data for certain communication can put the whole process at risk. And so, again, on the epidemiology side and the communication side, need to really have robust plans in place of if we test for this, what will we do? I often quote, there's a famous quote, be careful. Running a lab test is like picking your nose in public. You need to be careful. You need to know what you're going to do with the results. So I would encourage that with wastewaters. Before we add Ebola or Marburg or even common respiratory pathogens to wastewater, we need to know what we're going to do with it. So, thanks.
Yeah, just very briefly, I agree completely. One of the conversations that we had around surveillance of airplanes, which happens both in terms of air handling devices and in the toilets, is if it comes back positive for Ebola, who do you call? And it's not obvious, is even legally who you're supposed to call. I mean, CDC, but I mean, there's probably some other folks that you need to get on the phone. But I do think that one, similar to AI, is that this is already happening. And so I think what we need to do is take your very important point and operationalize it. And we need to develop these playbooks because we're already testing for all these different pathogens all over the U.S., probably also on airplanes, but we don't have the right plans in place for what we do with those data. And so I think it's really important.
Great. So I'd like to welcome the next speaker up. I appreciate the interest in this panel.
Good afternoon. I'm going to start some introductions while the panelists assemble here in the interest of time. So I'm Susan Van Meter. I'm the president of the American Clinical Laboratory Association. It is great to have this opportunity to meet with you all. Day 2 feels a little bit like getting dessert after broccoli yesterday because it is fantastic to hear ideas about what are short-term solutions to address, I think, a common set or a commonly agreed upon set of challenges that were outlined, I think, so well yesterday. So this panel, again, is focused on identifying short-term strategies, and we are going to hear from the following colleagues. Matt Vinegar, Director of Clinical Virology, Division of Clinical Microbiology, Department of Laboratory Medicine and Pathology at the Mayo Clinic. Matt, you're most welcome. Eric Connick, who is Associate Professor and Associate Director of the Genetics and Solid Tumors Laboratory and the Director of Genetics Pre-Analytic Services in the Department of Laboratory Medicine and Pathology at the University of Washington School of Medicine. Also on the panel in person, Grace Cuban, Director of the Texas Department of State Health Services Laboratories. And we have virtually 3 panelists. Gigi Granval, who is a senior scholar, Johns Hopkins Center for Health Securities, associate professor, Department of Environmental Health and Engineering, Johns Hopkins Bloomberg School for Public Health. Mara Ospinall, who is a professor of practice, FSC, College of Health Solutions, Arizona State University. And finally, Tim Stenzel, who, as you all know, is director of the Office of In Vitro Diagnostics and Radiological Health at the FDA. So you are all most welcome. We're very eager to hear from you. I'd suggest we try to keep presentations to about 5 minutes apiece. I think Q&A is so instructive, and we all appreciate that opportunity. So let's try to do that, and then we really look forward to taking your questions after the presentation. So Matt, we'll start with you.
Okay, thanks, Susan, for the introductions. Thanks to the organizers for inviting me. It's a real honor to be here. This is a topic I'm very passionate about, so I'm excited to dig in and figure out how we can respond better in the future. I want to start with the punchline, and that it is going to take all of us, including some who are not in this room from other sectors of our health response teams, for this to be successful in the future. So if there's one thing, again, that I can underscore is that we all have strengths that we can leverage, as Colleen mentioned in the last panel, but we also all have significant gaps. And so we need to lean on each other to make sure that those gaps are addressed. I'm not going to spend time on this slide because we talked about these challenges of COVID, monkeypox, Zika, Ebola in the past, but these help to frame our discussion on areas that we really need to dive in and address in the future. So again, leveraging each member of the team and their strengths is going to be absolutely essential to building up an adaptable infrastructure for response in the future. I start with public health. I have such respect for my colleagues in public health. They are the foundation of our response to emerging infectious disease and public health threats. They provide ongoing epidemiologic surveillance. And I would also say that there are many others within academic health centers and industry who are also actively involved in surveillance as well that we need to lean on more heavily in the future. Our public health colleagues have that early access to samples in the early days of an outbreak or pandemic, and accessing those is absolutely important for us to develop new diagnostics. And I do believe that CDC is and will be in the future best positioned to lead early test development efforts. Clinical laboratories, of course, I represent a clinical laboratory, and we've said this yesterday, and I'll say it again. The clinical labs, whether it be in hospitals, small clinics, commercial reference labs, these are the front line of patient care. They have the infrastructure for both hospital and clinic-based testing, and providing that rapid turnaround time for results where the patients are being seen is critical in controlling the spread of a new or emerging infectious disease. Industry. We mentioned this yesterday, that without including industry, we're missing a huge component to the laboratory response, because my lab, clinical labs all around the country are highly dependent on resources from industry, whether that be equipment, test reagents, collection supplies. And without having them as part of the solution, part of the equation, we will be missing an opportunity. They also are able to produce reagents and equipment at scale. So having, again, the necessary reagents, equipments to respond to an emerging infectious disease relies on our industry partners. And of course, they are set up for this. They have GMP manufacturing facilities that ensure that we have high quality and reproducibility. Of course, our government partners really play a central role in coordination of that public health response, funding, prioritization, and decision-making in terms of where testing is initially deployed and how that overall response should, again, be coordinated. And I created this Venn diagram to show that it's at the intersection of each of those strategic partners, public health, clinical, industry, and government, where we will best be able to prepare and respond. So I want to spend just a few minutes future-looking, forward-facing, and the key that I have continued to come back to is that we need to develop this proactive, adaptable infrastructure for public health emergency response. We can't build it each time it happens. It has to be something that we can go to and rapidly pivot from an adaptable infrastructure that is proactive. I wrote an opinion piece in February of 2020 as we started to hear about a novel coronavirus. And it was focused on why partnership is essential to control the spread of this novel coronavirus. And in that, I started to paint a picture of maybe that infrastructure that could be deployed, in which we have this coordinated strategy between public health, industry, clinical labs, and the government to respond. And really, my point in that opinion piece is that we need widespread testing during the early phase of an outbreak, not all outbreaks, but some outbreaks, especially those that are known respiratory transmitted diseases like coronavirus or avian influenza, to prevent broad community transmission. This is an image just to tell a story. It's not going to be accurate in terms of all of the LRN network sites, but currently we have a relatively limited LRN response network. And I would suggest that in the future, we need to move to a model where that is greatly expanded, where we have clinical laboratories around the country who are vetted outside of an outbreak or pandemic to contribute to that response. This can be done. I'm of the belief that high-quality labs produce high-quality results. And through leveraging colleagues with CAP, we can accredit these laboratories to be part of an emergency response network. I really appreciated Scott Becker's comments yesterday and use of the phrases peacetime and wartime. And I would have been trying really hard to communicate to colleagues and family members that we need to view response to emerging infectious disease like a military response. We need to start using that language because I have seen in my laboratory and at the healthcare centers around the country, those staff have been fighting a war against an invisible enemy, and we need to provide them with the resources to fight that war. So, how do we do that? Some potential solutions. And I understand that there are going to be many areas that I'm overlooking, and I don't mean to be naive to the challenges that each of these partners face. But I do believe that CDC and public health should identify strategic partners during peacetime that can be partnered with to help with our response, both clinical labs and industry. And I totally appreciate the opinions that were brought up yesterday about challenges of identifying certain strategic partners. But again, if we view it from the lens of a military response, we can do this. We can also identify strategic partners to help fight infectious diseases, as the military does to help prepare and fight against foes during military conflict. We can coordinate test development with industry partners to streamline the path to test availability and mass production of reagents. I brought up the point yesterday that test manufacturers have dedicated production lines, and they do not currently have production lines set up for emerging infectious disease response. They have to take down entire lines and shift work from one product to another. And the last point is clinical laboratories can be identified outside of an outbreak or pandemic, vetted, qualified, and then brought into the response if determined to be necessary. I also like Scott's comments about having different layers or triggers. We don't need to have all clinical laboratories involved in Ebola testing. We probably don't even need to have all clinical laboratories involved in monkeypox testing. It probably made sense to limit that to certain testing laboratories, and I thought the response with monkeypox was fantastic. But when we have a novel coronavirus or an avian influenza outbreak, I would argue that at that point, we need to have as much testing as possible and flip the switch and allow as many clinical labs across the country who have been pre-qualified and vetted as high-quality testing laboratories brought into that testing response. So again, I'll just end with this, that the intersection of public health, clinical laboratories, industry, and the government is where preparedness and response lies. And it will require all of our coordinated efforts for that to be accomplished. So I'm really looking forward to the Q&A session.
Matt, thanks so much. That was terrific. I think we're probably going to hear a lot of continuous hovering on public-private partnership. Eric, thanks so much for your presentation.
Okay. So again, I'm Eric Connick from University of Washington, but I'm representing the Association for Molecular Pathology today. And I think you'll hear a lot of echoes of what Matt just talked about. So just for those of you who don't know, AMP is a non-for-profit organization that really focuses on molecular technology for clinical diagnosis. And so we look at all the different areas, including solid tumors and infectious disease, et cetera. So just kind of thinking about what it is that I'm going to talk about is, from a physician's standpoint, we've talked about, these early areas of surveillance. We've talked about kind of the steady state where we have manufacturers and reference labs, high capacity, high quality testing, but there really is an inflection point. There's that point that we saw about 164 weeks ago, and that's when the public health emergency was declared. The first SARS-CoV-2 virus sequence was just 4 weeks before that. And so, a lot changed just in that first few weeks. And so we really need to think about how are we going to deal with that when this comes up again. And so, one of the things that we recommend is, diversity of types of testing and locations of testing, near patient, reference lab, public health, et cetera. We need all modalities. We need sensible regulatory oversight. One of the early barriers to actually implementing testing at that tip of the spear in Seattle was the regulatory barriers that were there. We had patients in front of us that needed testing because everything else was negative. They were symptomatic. They were piling up in our hospitals and our ERs. We couldn't offer that to them. They didn't meet the qualifications for testing at the reference laboratory. We also need reimbursement. Clinical laboratories, we rely on being paid for the work that we do, and we invest a lot of resources and personnel into bringing these tests up. If there isn't a way for the laboratories to get paid for it, that's not going to happen at scale at all. So a lot of the information is based on some surveys that AMP did in April and August of 2020. This is just a representation of the states from the laboratories that responded, so a good representation across the country. Also good representation of academic labs, community labs, and then reference labs. So this really does kind of encompass, that early experience. So one of the things that we saw very early in April was that, we already had high quality commercial tests that were available, and about 90% of the labs that were testing were using those. But what was really surprising is that about 50% of the labs were actually using laboratory developed tests. When we sampled again, just a couple months later, we saw a slight uptick in labs just using commercial tests, but we saw this persistence of laboratory developed testing. And this made us wonder, why do we have all these LDTs that are being used in clinical care? And the reason is that most hospital and academic labs were bringing up multiple tests. So we stopped counting at 3 here, but I can tell you that our laboratory had 6 or 7 simultaneously validated tests that were operating at the same time. If you look at a lot of the commercial laboratories, they had many, many fewer tests that they had validated simultaneously. And why was that? And it was because of the supply chain shortages. We literally didn't know from day to day, and sometimes even hour to hour, we're beginning to have reagents to do testing on platform A versus platform B. And that is a real big concern when you're looking at turnaround time. So again, we had these patients in front of us. We have our clinicians saying, I need to know what to do with this patient. Do I cohort them? Can I worry about down escalating my PPE precautions? All that was in short supply too. And the turnaround time was critical. So if you look here at the academic and the community labs versus the commercial labs, again, excluding the time to actually ship the sample to the lab, right? Because a lot of these reference labs you have to ship across the country. We're looking at about 90% plus of the results were being returned within 24 hours. That was allowing our hospital to continue to treat our patients. Surgeries, were able to continue. We were able to really conserve the resources that we needed to care for our patients in these really early hours where we didn't have the information that we have today. And so it was a really stressful time. And I was telling somebody yesterday, I went on vacation right before this happened, and my beard was not that gray. It has gotten very gray in 164 weeks. And I attribute it a lot to this first, I'd say, 8 weeks of the pandemic. The other thing is the EUA process. So this is more for just the people who have the copy of this, but there was a long timeline of different decisions that were made. But the public health emergency was declared on January 31st, and laboratories at that point weren't able to validate and bring up tests like they were the day before. They had to start going through the EUA process. And this was a really cumbersome process, especially in those early days. We struggled with it, University of Washington, for that first month. And then at the end of February, things changed, where we were allowed a little bit more discretion. Some initial tests were brought up. A few weeks later, The state health authorities were allowed to bring up EUAs, and we saw a massive increase in the tests that were available locally. You can see here the average date that EUAs were submitted. And you can see that the academic labs were really, very fast in getting those validations submitted for approval. And so the problem is that even in those early days, those EUAs were taking months to get processed. And again, this is from April, if I remember correctly. And months sitting there getting review. We've heard that there's potentially problems with these, but we also know from talking with laboratories that the problems were more repeating experiments and getting the same result using multiple different approaches. So this process was cumbersome. It needs to be more streamlined, especially these early days of a rapidly moving infectious agent. Reimbursement. So this is a quote from my chair of my department, Dr. Baird. He basically spent our entire reserve that had been built up over 50 years within 8 weeks. And this was basically building out lab capacity, literally knocking down walls so we could put instrumentation in, hiring people, et cetera. There was a very real chance that my department would cease to exist if we weren't able to recoup some of those costs. We did it anyway because it was what we needed to do for our community. But reimbursement is so key so that we can take these risks when the next pandemic arises. So again, going back to the focus and recommendations, we really need all the different types of laboratories, community labs, academic labs, reference labs. We need to support all those because we need those turnaround times. There's different reasons for testing, and in a pandemic, we're going to need all those different laboratories to be available and have access to testing. One of the things that Matt mentioned was this access to samples. One potential way of that is, can we include some of our key laboratories in the LRN? Can we get the access to those samples for validation, whether it is a laboratory-developed test or bringing on a manufactured test? It was a huge problem in the early days of the pandemic. We need to distribute supplies. We saw allocations going to places that weren't actually using those supplies, whereas we had hotspots like Seattle that weren't able to get pipette tips, reagents, et cetera. And then, in terms of regulatory authorities, what we saw that worked was that laboratories were able to bring up their laboratory-developed tests or their commercial tests and then submit the paperwork later and really benefit the patients that are right in front of us right now. That's really, really important. And then reimbursement, I can't stress that enough, is that we're going to be taking risks as laboratories, and we need to be able to recoup those expenses. And the reason for that is that so people will take those risks and they will build out the testing. Hopefully we don't need it, but if we do, it's there. So here's some QR codes for the AMP surveys, and I will transition to our next speaker.
Great, Eric, thank you so much. If you haven't seen those AMP surveys, they are definitely worth looking at. During the pandemic, most of the pandemic, I was working for the manufacturers, and we found those really helpful. And just a quick notation, we did week over week, when I worked for AdvaMed, we collected data from the largest manufacturers that were about 85% of the molecular market. And we actually found that when you would see a surge, you'd see we would be shipping more extraction reagent for LDTs, right? So that notion that you need to use everything you possibly can have available, even when you have EUA tests on the market from kit manufacturers. So great stuff. Can't wait to dig into that. So Grace, thank you so much for your presentation.
Good morning, everyone. I really want to thank the National Academies for the invitation to speak at this very important workshop and be part of this panel. So there's been a lot of great things I've heard already this morning. I'm sorry I missed yesterday's presentations. They sound like they were really wonderful. And I want to apologize in advance if I'm repetitive because I did miss some of that information. So at any rate, I was asked to talk about, really what is the laboratory's role, a public health laboratory's role in responses moving forward. So, one of the things that we know is that we must be ready to respond 24/7. Our partners don't work Monday through Friday, 8 to 5. They work much more than that. So we've got to be there to support them. We receive calls day and night, on weekends, on holidays, requesting testing for highly infectious diseases that might have a significant public health impact. So in public health laboratories also, we have resources available to us and access to non-typical testing methodologies to help us identify and characterize whatever might be the latest disease du jour. such as when the Florida Department of Health Laboratory identified Bacillus anthracis as a causative agent of what became the 2001 Amerithrax incident. Public health laboratories also have the ability to provide broad access to testing for lots of different populations, and that also includes the uninsured and underinsured. So we provide a niche for them so that they might have access to testing also. So the public health laboratory response to emerging or infectious re-emerging pathogen really starts with the CDC's Laboratory Response Network, or LRN. So I know we've heard quite a bit of talking about that already. But CDC really has been forward thinking over the last many years that I've been in the public health laboratory to actually release assays that try to address what might be happening on the global stage. In 2014, the DoD Ebola PCR assay was released to a limited number of LRN laboratories. Our laboratory was actually one of those. We had just basically implemented the test about a month before we actually tested specimens that were attributed to the first diagnosed case of Ebola in the U.S. So the LRN also provides us secure communications and reporting structure for test results back to CDC, so that surveillance of a public health threat can actually be tracked at a national level. In addition, the LRN labs have trained staff and resources to provide testing for emerging diseases in BSL-3 laboratories and to help identify and characterize rarely seen diseases. Public health laboratory personnel can also serve as resources to help bring up testing, say, during MPOX, when they helped with the commercial laboratories bring up that particular assay in their laboratories. They served as subject matter experts. They also are there to help support bringing up testing in non-traditional type of sites, such as helping with COVID-19 testing at schools and in community-based drive-up clinics. But let's talk about what can be happening, what things should we be looking at. And working to build an effective national laboratory system, several things can be done. CDC must revolutionize their LRN assays to be more flexible, scalable, and all FDA approved. CDC has really been working to optimize some of their PCR tests lately. We've seen them take their singleplex assays and turn them into multiplex assays. But we really need to have more of a consideration for thinking outside the box as we look at testing needs for the future and how we might address what might be coming up. So they really need to be developing assays that can utilize multiple platforms and automated extraction methodologies so that these tests can be made widely available and quickly scalable, so that they can be used in multiple different types of laboratories and to help increase our access to testing very early on. So, and also, really these assays need to be FDA approved before they are actually handed out, so that any clinical laboratory may be able to bring up this test. I think it's really important to have that ability to have an FDA-approved test being given out to laboratories. So all they really need to do is do a quick validation. Of course, they have to have material available, so source material is also a consideration. But being able to take that method, bring it up in their laboratory quickly, really helps accelerate the access to testing and provides, a broader base for who might be able to get these tests. And these tests really need to have with them some sort of inactivation protocols. This would allow these tests and assays to be used in BSL level 2 labs, so clinical laboratories, maybe at a hospital, a commercial laboratory. There's much more BSL 2 spaces available out there than there are BSL-3 spaces. This would actually be able to increase and leverage BSL-2 spaces and apply and allow us to bring that test up in multiple different types of testing laboratories. And it is really essential that we develop a surge plan that includes all of the LRN network labs as well as our partner labs. I know my colleagues spoke about that quite a bit, is leveraging those laboratories that are either out there. How do we bring them in to help provide mitigation steps against sample overload and backlogging of specimens? We really need to have those test results provided quickly, and so being able to leverage all of these different types of laboratories is imperative to a good response. And it's also really essential that the system engage academic institutions early on as part of research applications to allow for the development of a very tests that are redundant in nature. This would provide a robust set of assays that can be used to identify variants that might pop up. It allows for flexibility in being able to identify different types of testing that might cause an issue. So like what we saw with the Thermo Fisher, there was S gene dropout, but what we actually found out was that was actually very helpful because we were able to detect a different variant using that assay. So, but what else can be important for this response? We really need to have a reliable courier system for specimen transport from a variety of different entities to all different types of laboratories. Being able to transport those specimens quickly, being able to transport them to different types of laboratory is very, very important. We also need to have contracts in place for surge testing with commercial laboratories and other private laboratories to help us have a broad base of testing and also to help spin up the ability to test and provide that service to a broader range of individuals. So, Matt, you had a nice graphic showing where we might be able to increase our ability to provide testing. And we also need to have access to an interoperable system. So all of the local, state, and federal partners, as well as the private and commercial entities, need to be part of an interoperable data system. One of the earlier talks really harped on the fact that we need to be able to get test orders reported, as well as the case data associated with some of that, to CDC so that we can see a national picture. This would allow us to make better public health decisions. And lastly, we need to have a formation of a collaborative work group in order to identify a minimal data set that can be used for test orders. We again, talking about what information do we need to see, how does that help us make decisions about who, what, when, where. Having this ability to have a minimal data set that we're all using together would be very, very helpful. And with that, I'll go ahead and stop there and try to be short because I think there's a lot more still coming. Thank you.
That's great. Grace, thank you so much. Couldn't agree more with the recommendations, particularly on this last slide, and thank you for making them concrete. Now we're going to move to our virtual panelists. Gigi Granval from Hopkins Center for Public Health for Health Security is on the line, I believe. I don't see her on the screen. Just want to confirm that she's still connected. Oh, there she is. Okay, at the top of the screen. Gigi, I know you've spent a lot of time thinking about this from a policy perspective and have some very specific recommendations for policymakers. So you are most welcome. Please, over to you.
Thank you. Thank you. I'll be brief. So as we know, after a very slow start, eventually the U.S. did have a lot of testing available, and so through that process, it wasn't just the structures that were built, the new organizations like RADx and at NIH. It was also the relationships that were built from the private sector to the public sector, to be able to share information, to quickly confirm directions that were being taken, and to make things go more smoothly. And so our larger goal for this project I'm going to describe to you is really like, how do we make all these extraordinary efforts and all the the extra, the many hours, all the hard work that was put in, how do we make that not extraordinary anymore? How do we put that into institutional practice so that it's there when it's needed and we don't have to go to extraordinary measures to create it? So the study is it's online. It's a national diagnostics plan, and it's in preprint form. And due to the crisis in academic publishing, it's probably going to stay as a preprint for some time. But that's another topic. So it's the people who are part of this study is Susan Von Meter, our moderator, Sujit Rao, who spent some time in the White House during COVID, Tom Inglesby, the same, and myself, where we interviewed many people who were instrumental in making testing available across the country, and people from the public sector, and people like the CEO of LabCorp, or the relevant people at Roche. So this National Diagnostics Action Plan has a lot of recommendations. Some of the top ones to consider is, of course, that the testing needs to be considered part of a critical infrastructure and needs to be adequately funded. We need to have pre-event contracts. One of the people we spoke to were we spoke to some people involved in the Korean response. They had pre-event contracts in place before they needed to have testing, and it really smoothed the process of having testing available for their population. We need to do the same thing. We need to create a permanent private-public testing coordination body that would be available to start testing earlier, and accept that not all decisions to start the process to make testing available across the country are going to necessarily be needed, but that it's an important part of practicing this capability, which is critical. We need to, this body could help facilitate the acquisition of samples to develop tests, and it could run drills, and could be a transparent way that we can see the preparedness is being undertaken. Another recommendation is to bolster the strategic national stockpile for testing components. A lot of these recommendations are complemented by, I co-chaired a National Academies study looking at the Public Health Emergency Medical Countermeasures Enterprise, or FEMC, and what needs to be done to rebuild it for preparing for the next events. And one of our main recommendations is that we do need some sort of advisory body, so you have the stakeholders involved in planning and thinking about what the government needs to spend resources on, because you can't plan for everything. You have to make decisions to narrow your focus, and there's the lack of transparency led to things like ventilators being sent to hospitals that they didn't know were coming, or they didn't know how to be trained on. They weren't trained on. So there are lots of things that could be done when you have much more transparency and a place, a forum for public and private partnerships to take place. So I urge you to look at our larger plan, but just in general, we need to kind of make the extraordinary ordinary for testing. Thank you.
Gigi, thank you. It was great to collaborate with you on that and encourage folks to look at the report. Mara, over to you, and thanks for joining us.
It is great to be here, and appreciate all the discussion. Can you see my slides right now?
We can, thank you.
Okay, wonderful. I do have to start, Susan, with what you said at the beginning and just say I really like broccoli. So it was a great day yesterday, but continues to be a really fascinating discussion today. I will also be relatively short because I want to talk about issues that have not been brought up because there's been so much good discussion to this point. So I'm going to start with what I see are 4 core principles, and mostly on the broader spectrum. And I represent both the commercial labs, but also academia in terms of having a very large program as Arizona State University about the science and business of diagnostics. So I come to this with 4 core principles, very much overlapping with my fellow colleagues here. One is diagnostics brings knowledge, and knowledge is power. And that is the power to make the best decisions possible. Probably obvious to this group, but I think we need to recognize that while diagnostics played such a large role in the pandemic, it was often kind of the afterthought and not always the primary focus. So if we look back, did we need an operation similar to what happened on vaccines for diagnostics? I would say the answer is yes, and it's very consistent with what everybody's said. Number 2, diagnostics is the only way to slow a surge, but that trust is essential. Clearly, once we have people who know they are positive, it then is all about isolation, but it's only through testing that we have the ability to do that. But I would argue at many parts of the pandemic, there was not trust in the diagnostics. Number 3, my colleagues have all represented the labs very, very well, and there's no question the labs are absolutely critical. But I need to say we have to integrate home testing. There's a lot of questions about home testing, which is for another discussion, but we cannot ignore it. And we have to embrace it in the best way possible and ensure what I believe is the critical information that comes from home testing and ensure that that happens as well as possible. We cannot I don't believe we can put that genie back in the bottle. And fourthly, education is the foundation on which all of this is built. We need to explain and ensure that there's a broad understanding of the strengths and weaknesses of testing. If we lose the trust of the physician community, the providers, and the patients, that we've lost it all. And we need to ensure that that continues moving forward. So what I would say is I think that there are 2 major pieces that we need to do, and I call it about moving forward in confidence. And in our discussion, we can talk more about it. Yes, as everybody said, it's partnerships. The public and private labs, including academic and commercial labs, the FDA, and Tim will represent there. But these next 4 are not talked about as much and need to be. The test manufacturers, separate from the labs, the test manufacturers, for which now we have 29 different EUAs for COVID tests. Are all of those tests going to be available in companies a year from now? They're not. But we have to integrate those test manufacturers to do the best job and look at diagnostics and testing in a holistic point of view, not just from the lab point of view. Number 4, physician associations. I'm sure everybody has stories about physicians who were not well educated, who just, and I'm not talking about conscious falsehoods and misinformation, physicians who really believe tests didn't work and only work under certain circumstances, both lab tests and home tests. We've got to reach out proactively. Same with patient associations, which is more difficult to do, but needs to be done. And lastly, a bit biased here, but educational institutions. I then move to my second piece, which Gigi mentioned as well, but the frequent and regular communications. It has to start now. We need an infrastructure to do this. We may need a better national lab infrastructure, but we cannot wait till the next crisis. And one thing that many people in government, particularly in RADx, have talked about is the pre-competitive cooperation on next generation technologies. This happens at the Critical Path Institute, focused on biologics or drug treatments. We need to do this in diagnostics to make the right decisions on how to stockpile diagnostics and what are the next technologies that can help us fight future pathogens. So with that, I say thank you and look forward to the rest of the discussion.
Mara, thank you. Great comments. Appreciate what you brought to this discussion. Looking forward to the Q&A with you. And Tim, thank you so much for joining us. And I know we've already had a number of reflections yesterday and today about the EUA process. And I do want to commend the FDA staff for working around the clock. I know some of those EUAs actually were approved within 24 hours very early on. And I think over time with the 15-day review time, or the 15 days, I don't know, Tim, you'll probably describe the accurate way to talk about this, but to have a submission to the FDA, start testing, get that review done within 2 weeks, that was really helpful. The IVD town halls and the accessibility of your team members. So I know we all learned a lot collectively, and just want to thank you up front for all of the work that you and your team did, and looking forward to hearing your remarks now. So over to you.
Thank you, Susan. Pleasure to be here. And the office I lead was required to step up like never before. We had to date more than 6,600 COVID applications. We've closed 96.2% of them. We're still getting them. So it's been a tremendous effort on the part of the team I lead. Let me share my slides. Hopefully you can see them now.
We can.
So this is just showing the authorizations for original IVDs by month. We saw a steep rise in the beginning, a flattening more close to the present day. This shows a present snapshot of the many different types of tests. The first home collection device was actually a laboratory-developed test by LabCorp that was very innovative, and we were pleased to work with them and make that available. So I wanted to speak to the questions that were outlined in this session. So, the questions are at the top in the title. So the FDA continues to reach out to as many stakeholders as want to engage with the FDA on an input for EUA generic guidance and EUA generic template validation recommendations. Once this generic step is completed, we'll move into a pathogen-specific effort so that we have on hand well-vetted pathogen-specific validation recommendations that the community has input on. The FDA is planning formal guidance for preparedness work through, and we'll go through a draft stage and then a final stage, although we can't predict when the final will be. The first will be a generic format, and then we'll see what happens with specific formats. Once the draft is out there and commented on, we'll look at the comments and provide a final draft and move it through clearance. And the FDA is currently participating with future preparedness planning within the U.S. government, and it's very welcoming of participation in formats like this. I think the FDA policies, probably, in a review of them through the COVID pandemic, and then the MPOX policies are a source of learnings to prepare for the next pandemic. I mean, certainly the FDA, prior to the pandemic, was always reviewing and updating whenever needed. The February 29th, 2020 policy, which allowed laboratory-developed tests to develop their test, validate, notify the FDA. Once notified the FDA, they could begin testing immediately prior to any review, and those labs could continue to test while the FDA was reviewing their application. So there was no rush to complete that review, as the FDA then turned their attention to kit tests, which were critical to further expand availability of tests and to tests produced at scale, has been mentioned today. The MPOX policies are another source to address this question. We did take all the lessons learned from COVID. We right-sized it for the type of emergency that MPOX was. It seems to have worked relatively well. And as I said, we're also learning, we're engaging with stakeholders on learning about their thoughts on our response. It's a self-reflection by the FDA through stakeholder engagement, both for COVID-19 and MPOX. And many, and some of the panelists and many in the audience, I'm sure, have been on those calls. Next, coordination is highly dependent on U.S. Government leadership. Items such as a national stockpile for tests and testing supplies, I believe, is critical to making sure that, especially early on, there are sufficient supplies and reagents to meet the needs. Probably needs to be linked to prearranged key developers and understand what reagents and supplies those developers would use. And then for those prearrangements with key developers, the FDA has written a position paper, and Jeff Shuren and I have discussed the South Korean effort. It was mentioned earlier today, and we did appreciate that they pre-planned, prearranged. They were able to respond much quicker. In fact, they had a system to accredit labs to participate in South Korea in the response, and we felt like that was a tremendous benefit as well. But to have key developers prearranged, they understand what the validation expectations would be for various tests, that they would understand what the process was to submit those tests to the FDA for review. So all of this could be reduced in time and be able to make tests available at scale. The Independent Test Assessment Program, ITAP, is perhaps an ideal model to use for this type. In fact, took the validation, clinical validation, out of the hands of developers. This is something that South Korea did as well. The developers in South Korea did analytical studies, but then the clinical assessment was done by either the South Korean government or parties associated with them. And that's exactly what the partnership between NIH and FDA on the ITAP process did. And we were able to routinely authorize ITAP tests when the final bit of data was in as little as 24 hours, but it usually was no more than a few days. And then, preparation of validation recommendations for key pathogens can reduce the time. What are the strategies to implement unmet needs during the response? Well, the FDA has stayed engaged with stakeholders through town halls, the FDA website, and to provide alternatives, solutions for labs and manufacturers to use when there were shortages. Supply issues are key, and the FDA will continue to stay engaged and support efforts related to that. What are the, strategies to make sure that lab testing is available in an equitable manner? We did see shortages, and we did see the need for allocation, and that was undesirable for all of us. And again, prearrangements with selected extremely high volume test manufacturers that, these are lines that would be ready to be turned on once the test is developed and validated and authorized. Even prior to authorization, these tests could be manufactured so that upon authorization, they can immediately be distributed. In fact, during the COVID pandemic, we allowed any manufacturer that wanted to pre-position their test kits in labs to do that. Some of them took us up on that, so that as soon as the authorization came through for that kit testing, the labs could even be ready because they've already tried the kits out and knew that they would work in their lab and had confidence and met CLIA requirements. And then, of course, an adequate pre-supply and then supplying needs through the pandemic for reagent and test supplies as needed. In my talk, which I'll share email after this, so that this can be shared, a number of references that point to the FDA's thoughts on preparedness and lessons learned. And then I want to thank you so much for this opportunity.
Tim, thank you. Really helpful. Looking forward to your sharing those slides, so thanks for that. So I'm going to ask one question of each one of the panelists, and then certainly encourage folks who are here in person to come up to the mics to ask your questions. We've got about a half an hour left, which should leave us some time for a good discussion. So I want to encourage us all on the panel here to offer up one or two specific, so concrete recommendations that Congress and other policymakers can think about. As we discussed yesterday, Congress is required by September 30th under the law to reauthorize the Pandemic All Hazards Preparedness Act. That gives us a concrete opportunity to develop policy, right? So these notions around public-private partnerships, I couldn't agree more with Gigi's notion of having a concrete, durable, right, permanent public-private entity that is a forum that brings in all key stakeholders, public and private, within the testing ecosystem that are able to develop high-quality tests, manufacture and run tests at scale, and have the logistics in place to move samples around the country. I think if I had to come down to one key priority, it might be that, but I might get a second bite at the apple as moderators benefit here. So Matt, let me start with you, and then we'll go right on down the line. If you could offer a concrete recommendation or two, if you were going to speak directly to Congress and policymakers, what would you recommend?
So I think the thing that I would recommend would be to identify 4 to 5 strategic diagnostic test manufacturers in peacetime, in time when we're not trying to respond to an outbreak or pandemic, that would serve as go-to test manufacturers for novel or emerging infectious diseases, and then to look across the clinical laboratory landscape and think about ways that we can get the equipment needed to perform the test from those test manufacturers in the laboratories, again, in a period of time when we're not having to respond through chaos. When laboratories were trying to build up capacity for COVID-19, if they don't have the equipment to run that test, they can't respond. And the test manufacturers can't build the equipment fast enough during an outbreak to meet the needs. And so pre-placement of equipment that can perform high throughput testing, but also mid throughput testing and even point of care testing, pre-event is absolutely essential. So it's going to take upfront investment to place that when it's not needed, so that those laboratories are ready to respond when it is needed.
That's great. I'm just going to underscore, too, that Congress, in the omnibus bill that was passed last December, included some provisions of the PREVENT Act that gives greater authority to government to make bilateral contracts specifically with manufacturers. The language could also cover clinical laboratories, particularly those that can, again, operate at scale, run those high-throughput instruments that can really allow us to meet the testing demand across the country. We'd like to see some modification there to ensure that language is robust enough to allow for those agreements, but great recommendation. Eric, how about you?
So I've been in the laboratory industry about 25 years, always in a clinical capacity. And so one thing I could say is that I've never been in a laboratory that had enough space. I never had a laboratory that had the capacity to fit some of these really high throughput instruments, except for a few. And so I think that kind of to balance what Matt is saying is that, we really need to encourage the diversity. We really do need that capacity, not just located in a single or even a few types of instruments that are susceptible to supply chain shortages or other disruptions. Think of logistics and shipping, and we think about the winter we've had, and how many times shipping has been delayed, right? To put all of our diagnostic eggs in that basket, I think is going to set us up for problems. So I think thinking of ways to really diversify what it is we're going to be doing. And so again, thinking about these tools of how do we encourage the laboratories who can develop tests to be able to do that and bring those online, in a qualified manner using samples that are available. And the other thing to think about is, I don't know if we can put this into, codify this legislation or something, but this idea of like crisis standards of care, right? You think back to those early weeks of the pandemic, the samples we had in our laboratory, we didn't have an orthogonal method, except we did have whole genome sequencing. And so that was how we were able to identify our first set of samples. Those full genome sequences weren't acceptable to regulators, right? I think scientifically and in that setting, we need to think about what are the tools we have, what are the clinical needs, how do we meet them? So again, diversity and having flexibility.
Yeah, I think that makes perfect sense, right? Like when demand is astronomical, you have to use everything across all modalities, all tests as appropriate for all appropriate use cases. I think that makes great sense. Grace, how about you? What would be your key recommendation?
My colleagues have great things, and I completely agree with both what they said, but I'm going to harp on data. We need data to make decisions. And if we don't have these interoperable systems that can basically go all the way down to our colleagues at the local level and all the way up to the federal level, as well as encompass all of the other partners, whether they're academics, they're commercial labs, private labs, hospital labs, we need that information. And CDC has been working on basically to figure out a way to do that, but I think we need to accelerate that quicker. We've got to have that in place before we have the next big event, because the ability to make decisions based on data is paramount to us being able to, do we need to look to another laboratory area to send specimens? Do we need to concentrate on different places in the United States because they have a backlog of what's going on? Are we seeing different types of variants coming up in different types of populations? What's the background of those individuals? How old are they? Have they traveled? Where have they been? It's all goes back to collection of the data and what we need to be able to make good public health decisions. Thank you.
Excellent recommendation. I think that discussion yesterday we had and earlier today from our CDC colleague about, can we have a discrete and, minimum data set that is widely agreed upon? That is massively important. And again, focusing on what data do laboratories actually have and what do we not? Solidifying a policy that is common sense, I think, is tremendously important. But Grace, thank you for those comments. Over to our virtual panelists. Gigi, first with you, and then we'll go to Maya and Tim.
So the forum for a private-public collaboration on testing was you already mentioned, Susan. So and prevent contracts were also mentioned. So I will put in a plug for exercising this capability. It's not something that we should just hope will work in an event of a crisis. There should be ways to make sure that it works through drills that could be meaningful, but nonetheless, these kinds of drills work in other aspects of preparedness, military preparedness, and we need to make sure that we do the same thing here.
Gigi, thank you very much. Mara, over to you.
We've talked about broad preparedness, so I'm going to focus on education. We need to better educate first providers on the importance and the power of diagnostics. We need to work with medical schools, but also maybe a little controversial. We need to add diagnostics to continuing medical education boards. It's one of the biggest areas that is not on CME boards. to keep practicing physicians up to date. 47 states have CME requirements. Let's add diagnostics to those requirements and ensure that our providers are up to date with technologies and the strengths and weaknesses of tests today. So that would be my number one priority.
Perfect. Thank you very much, Mara. Tim.
And overlapping what Matt said, a plan in place akin to what South Korea had in place prior to COVID-19. Adapted, of course, for the U.S. Healthcare system. And in particular, prearranged agreements. They're in place with a small but diverse mix of key manufacturers that would produce tests for central labs, tests for point of care, and tests for over-the-counter home use. And the diverse mix has to include the diversity of instrumentations and the size of labs that are present in the labs today. So it does, build upon what labs are already have and already using. That doesn't mean we can't place additional instruments. Thanks.
Tim, excellent recommendation. Thank you. We have a lot of folks at the mics for our panelists that are virtual. You can't see them, but they've lined up. So thank you for your questions. And we'll start on this side of the room. And thank you for saying your name and your affiliation.
Jill Taylor, APHL. I want to follow on something that Matt said. That I think we need to change our thinking on, and that was that CDC should take the initial role in test development. And I agree with that to some extent, but every lab can go down. We cannot have a single point of failure. And so in terms of the pre-agreements, we should have a group of advanced public health labs, advanced clinical labs, advanced commercial labs who are primed as soon as there is the genomic information to get going, work with the FDA for that very early phase. H1N1 in 2008-9 came in through the south. SARS-1 came in through the north, would have come in and we dodged a bullet. So it has to be regional based as well as skill based. Thank you.
Yeah, I completely agree with that comment. I do believe because of where CDC and WHO are positioned kind of at the front lines of outbreaks that they need to be coordinating and leading the effort, but coordinating with key strategic partners in industry and academia, because as you pointed out, it's never good to have a single point of effort. And by coordinating that and broadening that expertise out, with having CDC kind of, again, lead those efforts is going to, I think, be successful.
Great. And on this side of the room, please.
Thanks so much. Really just to...
Could you state your name and affiliation? Thanks.
Oh, I'm so sorry. Tracy Goldstein, USAID. Sorry about that. Just two quick comments. These are two challenges that we heard yesterday and today that we've also obviously needed to address in the international setting is first, access to testing materials, so control material for assays and validation, and then also inactivation. And so somebody made a plug for this yesterday, but when it comes to control material these days, you can use synthetic controls that are made by the same companies that make primers. You can put actually controls in for multiple assays into one plasmid, and we've been able to use that successfully, and you can ship those across borders, grow, lots of those. So just want to put a plug for that. The other piece is working in remote settings, often having to have samples travel far distances, so inactivating them at the site of collection rather than labs having to manipulate them and inactivate them in the lab. And obviously many of the COVID tests utilize that technology that we were all doing at home. So it's just sort of a plug for that to sort of limit contact with potential pathogens. Thanks.
Yeah, great recommendations. Thank you so much. And on to Andy.
Yeah. Hi, Andy Scott. I'm the program manager of ICLN, the Integrated Consortium of Laboratory Networks on the federal side. I was really encouraged to hear from the panel, especially Gigi and Tim, talk about a strategic national laboratory stockpile. I think logistics is critical. This is one of the key elements that we identified with our 7 networks as a key element when we looked at our COVID lessons learned. And I would like to say or propose, though, that I think that is really a too narrow of a view of how we can address the problem, because I know that most of us are using just-in-time logistics that starts to break down when the population gets affected and starts staying at home. You know, God forbid we have a higher mortality event where we start losing a lot of people and a capability to move stuff around. So I think we have to consider logistics holistically as an enterprise, like we've been proposing on a lot of other elements that we've been talking about, and consider maintaining supplies at lower echelons, more like we did historically when we didn't have as efficient, supply chains. Identify alternate sources of supply for those items that we think are going to be in high demand and potentially low availability. Identify sources of critical items, equipment that we may need, and maybe stock those. That might be a central stock because it's going to be expensive. And just leverage all that capacity throughout the enterprise. So I think we need to look at the paradigm of how we do logistics and how that might change or need to change in the event of a large-scale incident. And not just bio. I would caution against us looking to fight the last war. There's another, or the last battle, maybe I should say, because the war is ongoing. But let's look at what the next battle might be, but consider that aperture a little more widely than just kind of a pandemic type situation.
Great comments. Annie, thank you so much. Logistics are massively important in all this. I don't know, Gigi, if you might have a response on the strategic national stockpile observation, and I know you've got some thoughts on ways to think about that in a more holistic sense.
Sure. So the problems with the SNS go well beyond the testing issues that we're focused on here, So yes, there's a lot of things that need to be rethought and to have also vendor managed inventory, to have more domestic or at least this continent available supplies in the case that it's that there are challenges getting supplies from elsewhere. Also new ways to make supplies. There's a huge biotech effort going on now with this administration to be able to have alternative ways to create some of the things that we need besides going well beyond testing, but using biotechnology instead of relying on petroleum-based technologies. So there's this is a really rich topic, which actually is the subject of more than one National Academies report. So yes, I think I agree with everything you're saying, and I think Tim also has something to say about this.
Yeah, if I could. I really appreciate the comments. We saw that there was one key swab manufacturer that was that due to the worldwide nature of the response had limited supply, and they were outside the U.S. So the U.S. government's absolutely looking at how we can support U.S. Geographic-based manufacturing. I've also been a strong advocate within the U.S. government pre-planning for what I call virtual stockpiles that address logistics and aren't dependent on one central authority to do that. Thanks.
Yeah, so many of us yesterday were just reflecting on the emotional response we have when talking about swabs, right, from early on. Yeah, so thank you for that. So I think like vendor managed inventory or virtual inventory, it's such an important mechanism that can be leveraged really quite effectively. And we've another question from the audience.
Jeanette Werner from Emory University. So we're talking about the diagnoses of disease X, the new SARS, the new whatever you want. Or radiation or whatever. However, we need to remember that there's a patient behind. And behind that, patient number 1, number 2, number 3, number 50, number 100, okay? They're gonna also want CBCs. They also are gonna want a complete metabolic panel. They're also going to want, especially if it's a respiratory disease, blood gases. I see that for disease X, we have all these people dressed up in, whatevers with peppers and blah, blah, blah. But in the clinical labs, in the lab that I direct, how do I convey to my staff, to all the techs, to all the laboratory scientists there, that we need to continue to do CBCs, this, that, and the other, in a BSL-2 for this 100 patients? And I think we need to look a little beyond this guidance that we have, that for this particular number of diseases, we have to dress up like da-da-da-da-da, but for all this other stuff, in the same patient, we don't need to. Point in case was the monkeypox, where we needed to do syphilis and a bunch of other things. And some of my staff say, but why are we doing this and not that? So we need to think to the future and try to figure out how do we incorporate all our lab techs, all our laboratory sciences into this melee that is happening, that we're treating, whatever number of patients.
Grace, Eric, Matt, any reflections?
This is Tim. So
Tim.
I would say that the CDC and the FDA have been already starting. We started the effort pre-COVID, but we've reinitiated the process of looking at the impact, not just on the specific pathogen test, and especially when you have bioterrorism potential here. How do you do tests across the board for all your patients, and you don't know who might be impacted by it? Also, the FDA is looking at supplies not just for COVID or Mpox, but across the board that are impacted by this. One, you mentioned various blood tests. So we've had blood tube shortages and almost to this day since the pandemic started. And we've been working with all the worldwide sources of blood, various Vacutainer or tube suppliers, to be able to address those shortage needs. Hopefully I addressed some of your questions.
Eric?
So I'm not sure how this exactly fits in, but I'm thinking of maybe best practices and things that we saw that worked during the pandemic. And so we had exactly the problems that you're talking about. People were concerned for themselves, their families, their safety, et cetera. And what worked really well at University of Washington was we were as transparent as we could be. And so, from basically day one, included all of our staff, in discussions. They had, hospital-wide town halls. Here's the state of information today, and really kind of got, especially in those early days, one of the things that we really conveyed on a daily basis was, this is what we think today, this is what we know today. That may change. And so we can all think back to masks, for example, right? The original guidance was not to wear a mask. We need to preserve those for our folks doing respiratory procedures. That has changed, right? And so that was really one of the interesting things is, a lot of people kind of think, oh, this is science, this is fixed, this is, the truth. And what we were able to change was that this is malleable and we're going to evolve as we need to. And it really, I think it encouraged our staff. And, we still had people leaving for retirements and things like that. But I've been so amazed at the dedication of our medical laboratory scientists throughout the entire pandemic. I mean, it's just been incredible. But it was from the top down, just being transparent and honest.
Grace?
Yeah, just real quick, I just want to talk a little bit about, we did see that during Ebola when basically clinical labs at the hospital, their staff did not want to work with Ebola patient samples or potential Ebola patient samples. And so one of the things that we really worked hard on was education. How is it that you can still handle that sample in your laboratory safely because of the type of testing you're doing? It's a little bit different than the type of testing that the people with the PAPRs are wearing. So I think it was very important to provide education as to why that testing is different and why you might take an extra precautions to do that. But most of the equipment that's used nowadays, of course, unfortunately, a lot of the manufacturers did not want Ebola run through their instrumentation, but there was a mechanism to ensure that some of that could be minimized. And the equipment that is there can be used. So it was really about education. And I really think it's most important to provide that information to anyone who might be testing samples where they see somebody on the news wearing a PAPR. Oh my gosh, they're wearing a PAPR, testing those samples. Well, how is that different? And so education, I think, is key on that.
Grace, just on that point, and I don't know if our colleagues from CDC here or Tim might want to make a comment on that issue.
I was just going to put something in the chat. So
okay.
CDC and FDA have already been holding calls with key manufacturers on as a result of the Ebola issue. We were very pleased, at least with a select number of key high volume and frequently used manufacturers in labs, that none of them wanted to void warranties or not tell you how to decontaminate your instruments. So we found a very warm reception in reaching out to the manufacturers. So I think the CDC and the FDA would appreciate hearing from labs when they know of a manufacturer that isn't willing to work with us on this. If there is an issue you know about, let me and I can and I think Ren might be willing to be a key point of contact for the CDC. To let us know, and we'll reach out to those manufacturers and work with them. Thank you.
Thanks, Tim. You got a thumbs up from Ren in the room. Beth, over to you.
Yeah. Hi, great panel discussion. Thank you for all the points that were made. I have two points. One, Grace, in your slide, I agree with almost everything you said except for one thing, and I'm sure Tim's going to have something to say about this, and I appreciate what Tim was showing, and I love the forward thinking of the FDA. They are very good partners to us. But you said you felt like we needed assays that were already FDA approved. And this is something I want to challenge our thinking on because, Tim already alluded to this, and so did Matt, right? We need flexibility with things that are already pre-developed, if you will, but we also need some flexibility. So what I'm asking is, and maybe Tim and his team have already thought through some of this, is could there be some kind of certification around a test? I don't know if this is the right answer, but just thinking through it, that some of these pre-qualified labs have, but when I can't get reagent X, I have some flexibility under what we already do today for CLIA or in some capacity so that I have a little bit more flexibility. It's just a thought, and Tim, you can add your thoughts later. I'm sure you've thought through some of this, but I just think we need some flexibility, particularly early on, because not only is swab a trigger word, but so is pipette tips. So the other thing is, and we haven't really talked about this much in the last 2 days, but it's something I don't want us to lose sight of, and some of it may be a little out of scope for this, but is the importance of implementation science and behavioral science on what we do when we report out test results. Because we can come up with the best ideas and the best test, but if it's not implemented correctly, and the behaviors that, as we know in this room, humans are humans, right? I just think, and maybe that's something, Maura, with the work that she's doing at ASU, I don't know if you're already thinking through it, but I would love to hear some thoughts, and I just don't want us to lose sight of those points.
Right, and I'll just say it so Beth Marlowe from Quest.
Sorry.
Grace, do you want to respond first?
Yeah, thank you. I think one of the reasons I really harped on the assays that are coming out of CDC that are maybe given to the LRN are FDA approved is if we have to scale up quickly, those can be given to multiple different types of laboratories. There are lots of laboratories out there that have the resources and the expertise to make their own lab-developed tests and can use those to do the testing. But there's a lot of also very much smaller laboratories that really don't have that type of expertise in their laboratory. They don't have access to be able to develop a test in-house. And so having an FDA test to be able to give to them, it makes it very much easier for them to implement that in the test in their laboratory. Thank you.
Yeah, and I would just add on that if we were able to get a number of authorized or approved tests out quickly within days or weeks, I would make the argument that would actually facilitate diversification. To Eric's point, diversification is absolutely essential because of supply chain issues, But once we have tests out there that are deemed as authorized or approved, that actually facilitates laboratories to make innovations and advancements and bring up other LDTs because now they have a comparator test. It was really challenging to develop an LDT in COVID-19 with nothing to compare to.
I just want to,
I have a
one thing great.
response to that if I could, if there's time.
Can I just add one point to Grace, Tim, is I just want to say that I'm not minimizing at all the need to standardize for those labs that don't have the expertise. I think we can do it in a way that's very standardized with a protocol. I'm just asking, is there a way we can do it with more flexibility? So go ahead, Tim, sorry to interrupt.
Yeah, and thank you, Beth, for your kind comments. And, throughout the COVID and then the Mpox pandemic, our guidances now have, replacement reagent and replacement supply allowances that provide the flexibility. The current regulatory framework, we can do pre-authorized change protocols where a developer can make those changes, but that does require a submission of the assay and authorization of that. So what the FDA views is essential is a modern framework of IVD and clinical laboratory test reform. The VALID Act had a provision of pre-authorization. So, anybody who wanted to develop a PCR assay could get a pre-authorization for that and not have to come in with subsequent development. So there's allowances for that type of flexibility, but it needs a modern framework. Thanks.
Tim, thanks for that. And I'll just, we can take one more question from the audience, and I'll just say on the VALID Act, at least from the ACLA perspective, we worked really hard on the Hill last year to improve really key components of that legislation that did not get across the finish line, but I think we made some improvements that appreciated the role of laboratories more than it did at the beginning, and certainly we think that legislation would be needed. Again, this is ACLA. Legislation is needed to actually have a truly modern framework. And so over to our colleague from CAP.
And Susan, if I can just add on
Sorry, Mara.
implementation, Ryan, this is something that actually in many ways encompasses so many of the comments on this panel. We need to ensure that the process works well from that initial submission of tests all the way through reporting. And I think it's a great more than a concept, but that we have to move forward with that to understand what that is and ensure there are no weak links in the system, because the laboratories can do a fantastic job, as they have done, in the analytics as well, but it has to be followed up and it has to begin and with an appropriate implementation. And that was one of the challenges that we had clearly at the height of the pandemic.
Thank you, Mara. Last question.
Thank you. This has been a great panel. This is, beyond broccoli, but I love broccoli too. So I'm Don Karcher. I'm the president-elect of the CAP, and there's a lot to respond to, but I'll hold it to maybe two key points. The theme, today seems to have been pre-everything, pre-authorization, pre-placement, pre-certification in peacetime. I'm not sure how we define peacetime. Like was said earlier, maybe we're just, past a battle, but we're still in the war. I'm not sure that we're ever at peace. But things were quiet enough that we can really think through, I think, a lot of these things. In terms of the point that Tim just made, and you had reinforced ACLA's position, CAP also did our best to try to get VALID to be the best it could be across the finish line. It did not get quite across the finish line, but one of the components that Tim mentioned in particular is the ability for laboratories to be pre-authorized or technically pre-certified to develop LDTs on certain platforms. We felt that was a great flexibility that would allow laboratories to develop tests very quickly without pre-market approval necessarily. So things could have happened sooner. And, Eric, you mentioned about the EUA process and it needs improvement. I would argue that would be one thing that probably could have worked, to our advantage during the height of the early days of COVID. It was also mentioned something that South Korea did very well, which is certify or pre-accredit laboratories to be able to respond quickly and gear up and very quickly. The CAP would certainly strongly support that. We'd love to play some role in that if we could. We actually already do something with the LRN, the CAP laboratory preparedness exercise, where twice a year, 1,200 laboratories are sent 3 challenges, which are basically attenuated organisms that they have to identify. These are safe organisms, they're not infectious, but they do have to have the proper containment facilities to handle these. And so there is already a lot of work going on now to prepare clinical laboratories. These are rank and file clinical laboratories to contribute in times of emergency times and to support the LRN. So we would love to continue to work on more of these things to sort of prepare clinical laboratories to be able to respond along with public health and large commercial labs.
Thank you. Thank you for your good work. Eric.
So the VALID Act certainly went through a lot of improvements and changes over the last couple of years. And I will say from the perspective of AMP as well as multiple other professional organizations, we have concerns even with the pre-author or the technical certification, I believe is what it was called, and the ability for academic labs and some laboratories to actually meet those requirements. And so, and I believe that in the setting of a pandemic, the EUA would actually supersede any technical certification process. And so we'd still be under EUA authorities is my reading of the VALID Act. So just so everyone knows, there is some controversy out in the professional realm about that particular piece of legislation.
Well, and so we look forward to working with Congress moving forward on the VALID Act and any number of things and encourage folks to weigh in with Congress on POPA reauthorization. I want to thank the panelists for their participation today, but to their continued dedication for the work that you are doing on behalf of patients and public health every day. So thank you, Matt, Eric, Grace, Gigi, Mara, and Tim. Thank you all.